everybody. Welcome, 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 welcome. Great to see you all. Thank you for joining. This is Heal the Wounds 2021, and we are discussing wound dressings, an approach to doing it right. Thank you, everybody, for joining. You're welcome. It promises to be a very interesting afternoon. We want it to be interactive. My name is Flora Coker. I'm the founder of Encapsulate Healthcare Solution, an organization that aims to give back, particularly in the area of wound management. We provide free wound management training for healthcare professionals. Initially, we started with healthcare professionals based in Nigeria, but now we have friends from all over Africa joining us. So we've extended it to all over Africa. So everybody's welcome. Everybody should network. The purpose of this training program is to improve your skills in wound management. We'll share learning, best practice, and so on, so that we can improve the care we give to our patients who have wounds. Now, I'm not going to take too much time introducing, but I want us to go straight to the first session. But before I do that, just a reminder to everyone, this viewer's discretion, that we will be showing pictures of wounds, so that everybody is aware of that. And all the information we are sharing right now, of course, is correct at the time of this recording. So please, viewers advisory. So that's that. So we're going to go into the first session, which will be a practical session, Q&A. We have some great healthcare professionals who are going to present a few case studies for us to discuss, and then we can all have some shared learning and input into that. Please, this is an interactive webinar. So if you would like to contribute, just raise your hand. Then I know where you are on the screen, and then I can ask you to unmute, and then you can share your comment or feedback or your contribution. Just a bit of housekeeping. Please do ensure that you are on mute because we are recording. If you're not the one speaking, please be on mute. Thank you very much. So our first presenter is Mr. Motoibo. I'll let him introduce himself briefly, and then he will take us through his case study. Over to you, Mr. Motoibo. You are able to share, so go ahead.
Thank you very much, ma'am. Thank you very much, Encapsulate. It's a huge privilege to be here this afternoon. That's where I am. I know some of us are in different parts of the world. Firstly, I want to appreciate Mrs. Farah for this huge, I consider it a huge privilege to be here this afternoon to contribute to healthcare delivery in Africa, and of course, the different part of the world. I'm Omoto Imbodemilade. I'm an healthcare provider, a nurse precisely, in Obafemi Awolowo University Hospital, Ile-Ife, Osun State, Nigeria. I actually work in orthopedics and traumatology department, male ward precisely. Then also I'm a postgraduate student with research focus on chronic wounds. So I've been at this for some few years now, and I hope that the few interactions we're going to have this afternoon will impact us positively. Thank you very much, Mrs. Farah. Thank you everyone for being here. So can I go ahead?
Yes, go ahead. Okay, while he's sharing his screen, just say good afternoon once again, and thanks for joining. I can see all those joining from Abuja, Ondo State, in Lagos. Thank you for joining. We have Ifeoluwa from, yes, Ifeoluwa, you're in Nigeria, but what part? Mr. Motoibo, go ahead. Just go ahead and share when you're ready, and then I'll stop.
All right, thank you, ma'am. So I'm going to share my screen now.
Yeah.
Okay. Mrs. Farah, am I on?
Yes.
All right, thank you very much, ma'am. Okay, so this is going to be an interactive session. Before we begin, I'm going to give an idea of what we want to, it's this one first. I want to give an idea of what we want to do, first of all, then I'll throw the question back to every one of us on what we think we should use to manage the case that we intend to present this afternoon. My second slide will give an entirety of the management, but before we do that, we want to have an interactive session first of all. So the case we want to present this afternoon is a case of a diabetic foot ulcer that has been scheduled for amputation. It's an infected wound and also poorly vascularized with offensive odor, and also with poor healing prognosis. Then also, it's also a wound that is quite slothy because it's infected. So I want to ask before we progress that what do you think we should use?
Okay, I hope everyone heard the case that Mr. Omotoyibo just described. Now we also have our experts panelists here. We have Dr. Irere and Mrs. La, who's a pharmacist. We also have, of course, Mrs. Babalola, who's also a specialist in wound management. They will also contribute to the discussions, but we would like the audience to give their thoughts on the case just presented. If you would like him to repeat it, just let me know in case you missed out some parts.
It's a case of diabetic foot ulcer. It's an infected wound, polyvascularized, and highly offensive. Then also with huge purulent drainage. Then also with poor healing prognosis. So we want to ask, first of all, what do you think, or what do you think? Some of us would have been involved one level or the other in wound management. I believe we have many healthcare practitioners there. What do you think would be the right choice of wound care agents and management for this wound?
Okay, if anyone wants to contribute, just raise your hand and then I'll ask you to unmute. Anyone want to contribute? How do you think we can manage this case? And if you've had a case like this before, what did you do? That can help others learn from what you've done previously as well. Don't be shy. Let's be interactive. We're all here to learn from each other. So just raise your hand if you'd like to contribute regarding this case. Okay, thank you. Mr. Olaoshun, go ahead.
Mute myself. Okay. And a wound like that, one of the things that I think we need to do is to ensure that we get rid of the odor that is there, and as well as try to remove any impending infection. So things like Actisop can be used as a primary dressing on that wound to limit the number of infection and to remove the odor. Actisop is a charcoal-based dressing product which is being used, and is as well as antibacterial.
Okay, thank you for that. Anybody else would like to contribute? What their thoughts about the case? Just raise your hand. Mr. Motoibo. Some people have just joined us. We might have to just quickly recap the case so that they can contribute. But if you're here already and you would like to contribute, just let us know before we bring the experts in to give their thoughts. Someone's hand is up, but I can't see their hand raised up. Who is it? Dr. Rere, whose hand is up? I can't see it on this side. Just raise your hand if you want to contribute to anything, please. No?
Someone's hand was up, but I'm trying to
Okay,
see.
all right, ma'am. Sorry, can you allow me to share my device, my slide? I think I have an issue here again. I had an issue with my device.
So Mr. Moto, but just quickly recap the case. Some people have just joined us.
Okay, I'll recap the case again. It's a case of diabetic foot ulcer, scheduled for amputation. It's an highly affected wound with a very high bile burden. Then also poorly vascularized. Then also offensive and poor wound healing prognosis.
So we had a contribution from Mr. Samson Olaoshun. Is there anyone else that would like to contribute? What are their thoughts in managing this case? Before I go over to the experts, please. So this is an interactive session. We need your input so that we can all learn together. We have different people, healthcare professionals joining us from around Africa. So let's share. Anyone else would like to contribute? We are shy for this first case. Okay, maybe you're still warming up. If you would like to contribute, just raise your hand and then you can unmute. Okay. Dr. Iriri, looks like no one is talking right now. Do you want to say anything?
Okay. I think that's it. Thank you, Mr. Motoiwo. Good afternoon, everybody. Thank you all for joining. I would say, based on, I think Mrs. Babala, I could hear her in the background saying, oh, maybe they should have shown a picture. I think that might be what is affecting some people and they're not able to visualize maybe, and that might hamper their thoughts to it. So can you all hear me properly,
Yes,
by the way?
I can hear you.
Okay, but having said that, I know that Mr. Motoribo is going to share slides. So the whole idea for what he's trying to say is just try and picture what it is. Now, if I hear him correctly, he said that this case, the patient is already scheduled for amputation. Mr. Motoribo, is that correct?
Yes, that was correct. He said so.
Yes, so he said the patient is already scheduled for amputation.
That's
in which
correct.
case, yes, in which case we are basically just trying to take care of the wound, let it look good. So what Mr. Mr. Sampson, I think. Is
yes.
That what I'm saying? Yeah, what he said about trying to take care of the smell is important. So now we're looking at not just outlook in terms of what it looks like, but also what is going on within. So if it's smelling, i.e. with the whole idea of purulent discharge and slough and all of that going on, then you have to take care of the wound itself as and how it looks. So chances are there is an infection going on, just like Mr. Sampson has said. So whether you want to use whatever absorbent material, it's important to clean the wound. So wound cleaning prior to wound dressing it's got to be thorough. So what you want to use for cleaning depends on what it is you have available. You have to maybe sometimes do a little bit of debridement, because he's mentioned that there was some slough going on there. So you probably have to debride the wound to the best of your ability, obviously knowing that maybe all the other healthcare team involved in this particular wound are available, the other members of the healthcare team. So it goes beyond just one thing. You have to take everything into wholesome consideration. But I don't want to go too deeply, so that I've just said this so that maybe people can talk as much as possible. This whole Heal the Wound session is everybody say something and we put it. So I don't want to like speak and people don't talk more. So if anybody can, I know Mr. Motoiwo, but you will still show a picture. But if anybody can just segue into what I've said, other people, so that it's not like, oh, expert opinion, expert contents. I just want to hear everybody's thoughts. We want to be sure that we're not just talking, people are actually able to do, if I've made any sense.
Absolutely.
Thank you very much.
Is there anyone that would like to contribute and their thoughts on how we manage this patient, this case, please? Just raise your hand. Anybody talk to us? Or should I call some? Oh, here we go. Thank you so much, Aishat. So just unmute yourself and make your contributions. Thank you. If you can put your video on, that would be great as well. Go on, Aishat. There we go. I can't hear you. I can't hear you at the moment. Let me just go to Abiodun. Just unmute, please, and go ahead. If you can put your video on, that would be great. Go on, Abiodun.
Good afternoon, the whole house.
Good afternoon.
Good afternoon, the host and the co-panelists. From what I heard from Mr. Omotoyinbo, the patient has been slated for amputation. Hello?
Yes, ma'am, can go ahead, ma'am.
Okay. The patient has been slated for amputation. I think the best thing to be done to the wound is just to make it look cleaner, because I don't think we are saving the leg from being amputated, if I may get the presenter right. Thank you. That is my own input. Just to make the legs clean and free of odor before amputation. Thank you.
Thank you very much. Okay, I shall try again. Unmute yourself and make your contribution. Aishat Khan, I think the person's having issues with their network. Anyone else? Dr. Pham, go ahead, please. I'm calling you Dr. Pham because that's what's on your screen.
Thank you. I greet everyone. I'm a student and I'm trying to learn here. But
well done. Go ahead.
Okay. Since the procedure is to be, there's a schedule for amputation, with my own understanding, first, there must be a clean management of the wound. There must be dressing of the wound. Either you are removing the odor with Actisol and at the same time you dress it properly so that it look okay before you can proceed for the amputation. That's my thought.
Thank you. Thank you. Someone else had their hand up. Mr. Motoibo, don't show your other slide yet. Don't show that slide yet. Just your first slide, please. Thank you. Okay. Damilare, go ahead.
Good afternoon, Max. I'm sorry for the sleeping tongue.
Good afternoon. Carry on.
Once the patient has been slated for surgery, there are some things we need to do before the person is being wheeled into the theater for the operation. Firstly, we have to keep cleaning the wound so as to prevent further breakdown of the wound that might even discourage surgery. And another thing we need to, the healthcare workers need to take note of is that we need to keep monitoring the vital, some important, medical signs in the patient, like the PCV level and all of that. So I think we need to monitor all of those things. We need to look out for the signs of maybe hypotension or hypertension that might actually discourage the surgery from occurring. I think all of those things need to be checked by the healthcare workers before proceeding to the surgery. That's my simple thought. I'm also here to learn because I'm a neophyte in the profession. So I came here to learn too. And I wish and I hope I will learn more here.
Thank you so much, Damilare. Yes, that's the plan, that you will all be learning and you will learn a lot this afternoon. Fantastic. Okay, I'll take one more person, one more contribution before we hand over to the experts, as it were. Anyone else? Any thoughts? Mrs. Lawal? You had some thoughts about the case? Go ahead and unmute and make your contribution, please.
Good afternoon, everyone. I will come in as a pharmacist to find out from this patient if he's on drugs, especially herbals that he's not likely to disclose to the doctors managing, that might interfere with the healing process or the surgery itself. So I will be interested in that. I will want to find that out and see what I can put in professionally as a pharmacist.
Thank you very much, Mrs. Lawal. Okay, so now I am going to hand over to the expert, Dr. Irere. She will introduce herself briefly, and so will Mrs. Babalola. So over to you. Or should we ask Mr. Motoibo to discuss what he did first? Okay, Mr. Motoibo, so tell us what you did first, and then we'll have a discussion.
All right, thank you very much, ma'am. I've had brilliant contributions from everyone that has commented, and I will say that the different comments that I've received so far, one way or the other, are actually part of the things I'll be talking about. I remember I heard from one of the comments that since the patient has been scheduled for amputation, then they should go ahead and amputate. That's really the opposite of what we want to look at. We're actually looking at how can we salvage many of these cases from amputation. That's using the modern wound dressing techniques, because the essence of the modern wound dressing techniques is to reduce poor prognosis of wounds. And of course, in a case like this, which you are looking at as diabetic foot ulcer, to reduce instances of amputation. So I'll recap briefly the things I said, and I'll keep them one by one. And I remember I said that we are looking at a case of diabetic foot ulcer, a case of an infected wound, poorly vascularized. If you all look at our slides, you will see the day 0. The very first picture, you can see that wound looks poorly vascularized. That wound looks infected, slothy, with ischia. Then also you can see that wound, looking at it, it has a poor wound healing prognosis. So the question is, what then do we need to do? Because we need to pick each of these issues one by one, and then address them using the modern wound dressing techniques. So I won't go much details of the history because of our time, but the very first assessment, we see that the wound is 10 centimeter, or was 10 centimeter by 8 centimeter. That's the length and breadth. And then we see this in the background, that this particular wound initially was being managed by traditional method. We have traditional wound dressing techniques, which if you're around this side of the world, because you'll be used to that, or you must have heard that one way or the other. That's the use of, for instance, you saw lotion, hydrogen peroxide, gauze, and all that. So this wound initially was managed using the traditional method, but we saw that the prognosis was bad and it wasn't improving. So then also we've seen that it's quite copious, offensive, purulent drainage, and all. So the question is, what then did we do? And that is the method. What did we do to handle each of these issues and eventually salvaging this wound from being, or this foot from being amputated? The first thing that we did was to ensure daily dressing. Now, daily dressing in all cases is not advisable in for all wounds, particularly a granulating wound. We don't advise to do it on a daily basis because it's not going to give an enabling environment for wound healing to take place. And the young granulating tissues will also be taken away or taken off when we do it too frequently. So in the case of a septic wound, an highly infected wound, it's important that we do it initially on a daily basis because of the purulent discharge and because of the high bowel body. So that was the very first thing we did. We commenced a daily dressing. Then also we took a swab for microscopic culture and sensitivity, what we call MCS, to know the kind of microorganism that this wound carries. So by doing that, we were quite so that we can be sure and precise on the kind of antibiotics, because this kind of wound also will demand we use a systemic antibiotics, which we did. Then also for the dressing itself, we also embarked on the use of tropical antimicrobial. Don't forget to mention from the assessment that this wound was infected. So definitely, systemically, we used antibiotics. Then also, we also use tropical antibiotics. And precisely this instance, we use dress lotion. Dress lotion is composed of povidone and metronidazole. Povidone and metronidazole. The metronidazole content of the povidone is an antimicrobial, but the metronidazole content helps to take care of the that's the anaerobic microorganisms, particularly ones that are offensive. It's recommended that we use metronidazole. So dress lotion is perfect for wounds that have high bowel burden and offensive. So we used that. And also guanidine is also an antimicrobial that was used, which also enhances granulation. Then we use process-and irrigating fluid as well. I remember someone mentioned irrigation. That's very correct. One of the things that we need to do in managing a wound like this is to ensure that the wound is properly irrigated, possibly an antimicrobial irrigating fluid, which Protosan will stand in that regard. So ensure, or in managing this kind of wound, we ensure that it is properly irrigated. In fact, to the point where you could possibly not perceive any more odor. So that was done. Then we can see Protosan gel here. Don't forget I mentioned that this one has a poor healing prognosis. So meaning that we need to use an agent that will enhance that's granulation and healing. And that was the reason why we also embarked on the use of Protosan gel. Then the 3M transport plaster. This is quite patient friendly. Some of our conventional plasters that we use sometimes the patients react to them, but 3M transport plaster has been proven also to prevent that from happening. So these are what we can refer to as other wound dressing agents, which I will talk about briefly after this slide. So these are the agents we used. Then one other thing that I won't fail to mention is the dietary regimen. We also ensure that we counsel the patient on high protein diet, because high protein diet definitely really required diet for this patient, because we are expecting to have healing or healing enhanced. So definitely we have to ensure that the diet of this patient is highly proteinous. So in doing all that, then let's look at the results. The Doppler ultrasound revealed initially that the arterial insufficiency, that this wound was not well vascularized, that is revealed an arterial insufficiency. So meaning that we also have to ensure that the wound dressing is properly done and the right agents are used to increase or to improve the arterial sufficiency, because that's one of the goals standard of wound dressings, to ensure that there's the wounds are well vascular. But when the wound is filled with sloths, is filled with purulent drainage, is going to impede vascularization. So the Mrs. F, that's the patient now we're looking at, was earlier before amputation, but neither this was done. Then don't forget we also, used, or we did not use skin grafting, because at the initial, when the wound was improving, so the medics now we're suggesting that probably we go for wound grafting, but we insisted that let's continue with these agents, and eventually skin grafting was not done. But we continue with the use of Protosan gel, which of course rapidly ensure the closure of the tissue and a drastic reduction in the offensive and the purulent drainage, also enhancing that's the vascularization of the wound. So having done that, after 6 weeks, we can look at the slide. You can see the remarkable improvement. Here, you can see the wound bed looks healthier. The very first one, the day 0, we can see that it's quite just filled with ischia. So the use of Protosan gel, helped to soften the ischia, and the use of Protosan irrigating fluid helped to reduce the bowel burden. So all that led to what we have in day 3, day 6, and of course day 12. If you look at week 8, week 0, week 4, then week 4, week 6, and week 8. Now, if you look at week 8, we can see that the wound edges looks much more healthier, and then it looks as though it's closing up. We can see that here definitely it's obvious that the wound or the foot was salvaged. If you compare week 8 and week 8 and day 0, we see that there's a large difference. Obviously, from what we can see in week 8, we can predict that this wound definitely the purulence would have gone down, and there's a very, very, very good prognosis for wound healing. So eventually this wound was not grafted, and it completely healed up from what we have from day 0 to week 8. Now, because of our time, I will just go to the next slide and then briefly put together what we did so that it can be clearer to us. Now, from this next slide, we see 3 things, or 3 items. Sorry
to interrupt, Mr. Omotoyibo.
Okay,
I would want us to discuss this later on when we're talking about amputation. prevention.
Okay.
So what I would like us to do now, so I want to keep, everybody should just hold the thought and kind of keeping you in suspense as to what happened. Please stop sharing your slide. I want us to go straight to the second case study. Just hold your thoughts, everyone, on this one. I will come back to this because this is very interesting, how the input helped this patient who was slated for amputation, and there was a much better outcome than was initially expected. So we'll discuss that in the fourth session. So if Mr. Ibikule is ready, he can come up with his
Now,
case
just
study,
need
please.
to put the slide on now.
Thank you very much. And if you have any questions about what is being discussed now, please pop them in the chat as we move to the next case study. We're going to go in more detail into this first one because the outcome was very pleasing for this patient. If you have any questions, just pop them in the chat. If you're just joining us, you're welcome. Thank you for joining. You can let me know. I'm sorry? Yeah, so you can let us just know where you're joining from in the chat, and we can acknowledge you. Thank you so much. Right, so Mr. Ibikule is sharing his slides now for the second case study. Yes, we can see that, so that's great.
Mr. Ibikule is coming on now.
Thank you very much. Welcome to Pharma Hub Nigeria. Thank you so much. They're great supporters. They're always sharing my posts. Thank you. You're welcome. Okay, Mr. Ibikule, over to you, even though you're the name on the screen, but this is definitely Mr. Ibikule. Go ahead. You're on mute.
Good afternoon, everyone.
Good afternoon.
Yes, I'm Ibikule Israel from Nigeria. I specialize in orthopedics and traumatology nursing, and my subspecialty is in wound care nursing. There is a case scenario before us this afternoon, and that is a case of a grandmother aged 85. That was at February 2021. Who was discharged against medical advice by her children on account of a sudden development of a prayer ulcer, which was not the primary cause of admission, so on the buttocks. And she also had a wound on the left ear. So I want us to discuss, actually, this wound, by dimension, the length is about 12 centimeter. The depth was around 4 centimeter, while the breadth was like 6 to 7 centimeter then. So purulent, slothy, and the woman was in pain as at presentation. I like us to discuss on this and then see how.
Okay. So how would we manage this case? Let's do like we did before, and let's see how would we manage this case. Just raise your hand if you'd like to contribute. And then I can ask you to unmute. How would we want to manage this case? Anybody raising their hands? Any thoughts, anybody? What would we do? Don't go shy on me again, no. Unless I call some people. How would we manage this case that Mr. Ibikule has presented to us? So there's somebody on here, Galaxy A2. I can't see your name. Can you unmute and give us your thoughts? You're on the screen as Galaxy A2. I've been told to call you to contribute, but I can't see your name. Are you there? I don't know if they can hear me. Can everyone hear me?
Yes, we can.
Oh, great. Okay. All right. Okay. So, Galaxy 8, if you're there, if you want to contribute, Mr. Okay, the person is Abiola Ogunlewe. Could you unmute and contribute? And how could we manage this case? What are your thoughts, Abiola? I believe you're one of the nurses. Okay, go ahead, Mrs. Babalala.
Hello?
Hello, go ahead.
Yeah, for a case like this, most of the time it is better we start from the preliminary, ensuring that the patient is on air bed. It is not right to have a very huge bed sore of that degree, but to manage such, the first thing we ensure we have a hair bed, we keep the wound clean, and then look at means of resources or generating granulated tissue. Because from what we can see in the presentation is a large wound, and with the age of the patient, the nutrition has to also be looked into. And then the agent of dressing, because there is no magic dressing. If they have been using a particular method, if it's not with assessment, they can evaluate, change. Positioning of the patient is very, very important. Hydrating the patient, very, very important in managing a case like this.
Thank you, Mrs. Babalola. Mr. Ibikunle, please could you just repeat the case? Abiola wanted to contribute, but she couldn't hear some of what you were saying. So just repeat the case for us. Thank you. Just quickly. You're on mute.
Thank you.
Just share your screen quickly and just repeat the case for them to contribute.
Okay, this is the screen. I believe all.
Yes.
Yes, a grandmother aged 85 was discharged against medical advice by her children on account of a sudden development of a prayer sore on the buttocks and another one on the left heel. This woman presented this case in the house, and then the wound was offensive. By dimension, the length was 12 centimeter. The depth was between 4 and 6 centimeter, while the breadth was 6 centimeter, and the woman was in pain, irritable, and always crying every time. So that is the case scenario.
Okay, thank you. So Abiola, just raise your hand so I can ask you to unmute so that you can contribute. Okay, go ahead. Thank you. Is it possible to put your video on as well?
Good afternoon, everybody.
Good afternoon.
I would like to be excused from using the video.
All right, go ahead. That's fine.
I'm quite unkempt. So I want to know if the pressure sore was developed while she was on admission.
Yes, she was developed while on admission. Our primary cause of admission was avascular necrosis of the left limb. The toes were not properly vascularized, which led to amputation below the nail. And in the course of managing that in the hospital, she developed a prayer sore and massive. And the children were like, we didn't come here with this, and so we are leaving. So they discharged themselves and reported at home.
Okay, so the place of turning and treatments of pressure area, cannot be overemphasized in treating in patients that are bedridden. So I feel that she was poorly managed while on admission. That's my opinion, because there is no reason for her to develop a pressure sore while on admission. It's a case against nursing care or whatever care that should have been given. So I think that's my opinion. If she could develop pressure sore and while on admission, I think that's a negative for nursing management.
Thank you very much, Abiola. Akini, you had your hand raised. Do you want to raise your hand again so I can ask you to unmute? Akini Aishat, or is it the other way around? You had your hand raised earlier on. Okay, so unmute yourself, please, and then go ahead.
Yeah, good afternoon, all.
Good afternoon.
Can you hear me?
Yes, we can. Go ahead.
Yeah. I would like to say, first of all, I'll agree with the earlier speaker who said
yes, go ahead. We cannot hear you. Your line is breaking. We cannot hear you. Okay, is there anyone else that has any contribution, please? Just raise your hand if you have any other contribution, please. All right, go on, Mrs. Babalola.
I just want to add that with the age of this patient.
Mrs. Babalola, you're on mute.
With she is presenting, this grandmother has some morbid states and pre-morbid states that predisposes her to this bed sore. And so most of the time we are managing just the patient, the old patient. So we need to also want to see other predisposing factors that has given her. Maybe she's not feeding well, maybe she's bedridden, maybe she has to be looked into in managing this patient.
Thank you. All right, Blessing, go ahead.
Okay, good afternoon, everyone. My name is Blessing.
Go ahead.
Hello, can you hear me?
Yes, we can. Go ahead.
Okay, from Lagos. In this case, I think the management should start with the nurses, frequent stunning of the nurses, and the use of hydrocolloid dressing. This hydrocolloid dressing, it contains gelatin. I don't know if I'm correct, but I know I've nursed a pressure sore lady, and we use hydrocolloid dressing. This dressing absorbs the wound fluid and it turns it to gel. Hello, can you hear me?
Yes.
So from my own point of view, I think this dressing should be done using hydrocolloid cream and frequent stunning, and also we should consider the nutritional aspect of. Hello?
Yes, go, continue.
Hello?
Continue.
Hello? Hello, can you hear me?
Yes, we can.
Sorry, I'm in a very noisy place, so I'm trying to. So like I said, we are going to put in consideration 3 things here: frequent stunning, diets, and the dressing we use. In pressure sores, we always advise people to use hydrocolloid gels. That's my own contribution.
Thank you very much for that. Thank you. Okay, so Mr. Ibikule, over to you, so you can go ahead and say what was done for this patient. You're on mute.
Okay, thank you, Ma. I want to appreciate as many of us that have contributed. We have said part of all we did for the patient. So the picture before us is the image of the wound at 8 weeks. So I was trying to locate the picture of the wound at presentation, but I couldn't lay hold on that. Now, this is the picture at 8 weeks. I'm trying to, sorry.
Dr. Rere, sorry, I think Dr. Rere had a contribution or wanted to say something.
Hello, Mr. Motoibo, sorry to cut you short.
Mr. Ibikule.
Oh, I'm sorry, Mr. Ibikule, because I'm saying Mr. Motoibo's name. Okay, can I just ask, because can you all hear me?
Yeah.
You hear me? Mr. Ibikule, please, before you say what you did, can I please ask any of the participants who is not like in a tertiary center what maybe they would have done? Like anybody who is in, I don't know, like maybe like a secondary or a primary healthcare center, what they would do with this sort of wound before you say, because you are in a tertiary center, am I correct?
Yes.
Can I ask anybody? This is why Mrs. Flora had been asking that, please could you all put out where you are joining us from, because the whole idea is, whilst we may know what's the right thing to do, we're also trying to find out what you are able to do in your center. That's the point of most of what's this discussion today. So if there is anybody, please, that is from a non-tertiary center, whether private practice, you know, whether you're in a primary healthcare center or in a secondary healthcare center, in a general hospital or something. Is there anyone? Because we'll start to mention trade names and certain things that is probably highfalutin to some people. What would you do for that sort of wound?
Please raise your hand and then I can ask you to unmute.
Okay, Mrs. Flora, so that we don't waste any time, he can go ahead. I just wanted to bring that out.
All
right, that's fine. Okay, go on.
So we needed to take the history of the patient, and that was why they told us all I said the other time. So we started with wound management assessment. We took the general patient history, how it all started, and we told the woman was very strong, agile, and very active before they discovered that she had a sore on her toes, on the right toes. And then gradually it progresses, it ascended, and they presented in the hospital and resulted to eventually to amputation below the knee. And so the woman basically had 3 wounds on her. You know, the post-op amputation, the wound was not, you know, the dressing was still there on the right stump. Then on the left heel, there's another wound, and on the buttocks, there's another wound. That's prayer sore. So we took the patient history, and then we had all those information. Then the measurement, we took the measurement of the wounds, the length, the depth, and the width of the wound. And that was what I said the other time. On assessment too, we discovered that the wound was slothy. This is part of it. If we look very well, we'll see the creamish tissue there. So the wound was slothy. And then each time you arrive to dress, in fact, as the woman sees us, she starts crying and then psychologically feels the pain. She cries for pain and all that. So before we dress, most times we needed to give her, you know, analgesics. Then we also asked we asked the relations about the diet regimen, how is she feeding? And we addressed that. Psychological impact on the patient as well as the relatives. So the woman was of the opinion that some people are after her life, and you know, initially she was active, and all of a sudden she just broke down in this, and the relatives too
Okay. Can everyone still hear Mr. Ibikunle? If you can hear him, let me know, please. I can't hear him. All right. Okay.
Can't hear him.
All right. Okay. I think his network is frozen. I can see from here he's frozen. That's a shame. We're really getting into that. Okay. So while he's trying to log in, I am going to ask Mojisola Maitami. Apologies for that. Something is wrong with Mr. Ibikunle's network. Mojisola Maitami is our next presenter for her case study. Or does anyone have any questions about the case that Mr. Ibikunle was discussing? Any questions that they want to put to the expert while we're waiting for him to log back in? Mr. Ibikunle, are you back with us? All right, continue.
Can you hear me now?
Yes, continue to where you left off. Just share your screen again.
Okay. Only the host can help me share.
Oh, 1 second. Don't worry. I'll make you. Yeah.
Okay. So if you look
All right, go ahead.
into the wound.
Yeah, share. You should be able to share now.
Yes.
Just bear with him 1 second while he shares his slide again. Okay, Luafemi, you have a question. I'll come to you after Mr. Ibikunle finishes. Oh, Luafemi, you can type your question in the chat just so that you don't forget. So then when it's time for me to call you, it will be there for you to remember. Just type it in the chat for us now so that you don't forget. Okay, thank you. Okay. Right, if you just joined us once again, thanks for joining. Let me know in the chat where you are joining us from and where you work. Like Dr. Rere said, we want to know those who are working in secondary settings, in community settings. If you're a community health extension worker as well, and you deal with wounds, put that in the chat as well. We're here to help you, and you can also post some challenges that you may have that we may be able to try and help you with. Okay. Because of time, I think I'm going to move on to the experts to contribute, to give their own contributions to the case that was just discussed so that we can speed things up. So, Dr. Herrera, Mrs. Babalola, and Mrs. Lawal, if you would unmute yourself and just contribute to the case, please.
Good afternoon, everybody. Thank you once again. Mrs. Lawal, I think I want to let you start this one before Mrs. Babalola. Mrs. Lawal.
Yes, I'm trying to spotlight her. Mrs. Lawal, where are you? I've lost you. Please unmute Mrs. Lawal and go ahead.
Good afternoon again.
Please, can we see you?
I don't even know where we are now. I lost contacts and I just came back on.
Oh, I see. Okay, Dr. Rere, you go ahead then.
Well, thank you, Mr. Ibukule, for your case presentation. Okay, so the one thing that I think one of the nurses initially had mentioned, he highlighted a lot of information, but he didn't give us duration of the problem. In fact, at the slide, if I remember correctly, he said the pressure sore was sudden, and I don't know how pressure sores can be sudden. I think I saw that it was unexpected, something along the lines of that. But again, in the process of his talk, he did mention the fact that, or somebody asked that she had been on admission. So we don't know how long this was. Now, think about it. She's an elderly patient. She is likely, she's lost some of her body mass, muscle mass, muscle tissue. And like Mrs. Babalola mentioned at some points, in the nursing care, they should have factored that in, that she should probably be on an air bed or some sort of pressure mattress, and make sure that they do a lot of bed turning, side back-to-back turning as much as possible. We don't really know what her anthropometric measures are like. Is she overweight? Is she obese? Is that going to be contributing to all the pressure? Every time you're talking about wound care or wound management, irrespective of what site the wound is, offloading is extremely important to improving a wound. Offloading, because friction, even if the person is not very, very big, but there is friction from maybe the bed sheets or even the sort of clothing, will cause the skin barrier to be, I'm a dermatologist, I'm going to always bring the skin into it, the skin barrier to be compromised. And then you can have from little excoriations to larger ulcers, and then to deeper ulcers as well. But be that as it may, not even skin, just by virtue of how a patient is positioned, you will have that. Now, Mrs. Babalola also mentioned that we don't know her comorbid conditions, and that's extremely important. In this side of the world, 85 seems like, oh, she's elderly, so let's just be managing her. No, you can have very good quality of life at 85 and above. And it shouldn't be discounted as that, oh, because she's elderly, then we can just manage and just be managing the wound, so to speak. So does she have comorbid health problems that may be contributing or even worsening this condition? Because we don't know why she went into the hospital. Pressure shows just tells you that she's a medical patient and she's been admitted for a bit, or at least she's not being mobile. It wasn't also said if she does have immobility as part of her problems, or it was in the process of this. Because for you to have a pressure sore on like the heel, it means that maybe little things, there's some simple things that people do. Maybe if you don't have an airbed, you could have done all that, where you put water in like a glove and give you some sort of airbed or water bed, so to speak, and put it under those pressure areas. So the heel, the elbow, like the crook of the elbow, the toes, which is, and she's having to stay on her side along the ischial tuberosities and stuff like that. So those are little things that could have been done. But having said so, if the wound has already happened, it is for us to stop wound progression, pressure sores or otherwise, in which case offloading is extremely important. So if you don't know what is causing a wound, you cannot begin to try to help the wound. In this case, Mr. Ebukile has already said it, that it's a pressure sore. We are taking his word for it, that this is the cause of this ulcer. In which case, from the very get-go, prevent more. Otherwise, you are pouring water. If you have the fantastic wound dressing, hydrocolloid dressing, some fantastic biogauzes and whatever, all whatnots, and you maybe don't have a negative pressure chamber, you are just pouring water into a leaking basket. So the important thing is, what is the mechanics of that wound? How do you correct that before you now start to say, let me take care of the wound that has opened up? First off, let me let Mrs. Babalola go ahead and speak.
Thank you. I want to say that it's very important for us at this training center to correct the ignorance of our people managing our patients. This patient, if you trace back the cause of the pressure sore, most of the time our patients, they use hard foam to replace her bed. It has been observed within 7 days, this hard foam creates bed sore to our patients. And then we also need to note the duration hospital stay because of the primary condition that brought this patient. When you start having a patient 2 months, 3 months, on bed, they have a tendency. And that's why we are saying hospital policies should be brought in to introduce branding scale to measure avoidable pressure sores should be prevented. You want to check the indicators and then do the needful, go for the preventive, eliminating avoidable pressure sores. Or like you rightly said, when the pressure sores are created, then we need to manage the sores. Maybe from stage 1 to stage 2, stage 3, and even unstageable with the modern products to give quick healing. These are my contributions.
Thank you very much. Okay, so that's the end of the, well, not the end, but at least session 1 with the practical sessions, with the practical examples, with the case studies. Now, what I would like for everyone to do, and I'm just going to remove the spotlight for everyone. Just give me 1 second. I want your feedback, and the reason I'm doing this now is because, once you leave, you forget, and I need to know, how you found that. As I said, we will talk about the patient who was scheduled for an amputation later on after Mrs. Babala's talk. So if you would not, I would like you to please just answer these, just do this poll for me quickly. It's only going to take us 1 minute. You should be able to see it on your screen. It should take you 1 minute so that the presenters can have some feedback from yourself. If you just go ahead and do that now for me. Can you all see the poll? Please let me know if you can see the poll. Just say yes in the chat. Okay.
Yes, yes.
Thank you. I haven't seen anyone responding yet. Please go ahead. It's just going to take us a few seconds. I have one person. There are over 50 of us on this. Please, let's just quickly give some feedback. Thank you. I'll just give you just 1 more minute. Thank you. Thank you to those who are completing it. Just quick one. While you all catch your breath as well. Thank you. Thank you. Just a few more. Got 13 people. I just need 20-something more people. The speakers would really appreciate your feedback. Thank you so much. Please excuse us for the some of the network issues. I'm giving the speakers time also to have some water or something before we go to the next session. Thank you very much. Let's try and get to 40, please. We've got 24 people just who have responded. Let's try and get to 40, please. Thank you. Oh, thank you so much. Yeah, keep going. Keep going. If you have any actual comment or feedback you want to send to me, just send me a direct message in the chat. If you want to type if there's any specific thing you want to highlight to me. This is also that we can do things better the next time. Thank you. I just need 12 more people, please. And then we'll go ahead because of time. If you have any specific thing you want to highlight, just send me a direct message in the chat. All right. Just 10 more people and we'll stop. We have 32 so far. Just 10 more people, please. Just give us some feedback. Ten more seconds and I'll close it. It's anonymous, by the way, so the speakers won't see who said what. It's anonymous, so just to let you know that. Okay. All right. I'll end it now. Thank you. Okay. So we're going to go into the second session now. Thank you to all those who completed the feedback. I'm going to hand over you to Mrs. Babalola. She's the Deputy Director of Nursing at Obafemi Awolowo University Teaching Hospital. She has over 20 years experience in wound management, and she will say a bit more about herself before she starts. Mrs. Babalola, over to you. Unmute yourself and you should be able to share now. Unmute yourself. There we go. Yeah, it's coming up now. Okay, we can hear you now.
Okay. Good afternoon, everyone. It's a privilege to be here, and I want to appreciate Mrs. Flora for this innovation and giving back to your country, as we'll be discussing this afternoon. Practical wound dressing. Are you doing it right? I'm Mrs. Baba, a Deputy Director in the Teaching Hospital, Ile-Ife. I will be looking at some outlines this afternoon. What is wound? Choosing the right dressing, types of dressing, duration of dressing, current trend in wound dressing, lotions for dressing, causes of delay wound healing, and the role of dressing in wound healing. Having practiced in the area of wound management for over 30 years, I want to define this afternoon that a wound can be defined as a break in the continuity of body tissue as a result of external action, either as a cut or trauma. It can be broadly categorized into acute or chronic wound. Wound dressing is just the process of assessing and cleansing a wound using septic technique. You find out that most of the time we run out of this rule, and as a result, our wounds get infected and they don't heal. I want to say wound healing and preventing that wound from further damage will be achieved if wound dressing is done aseptically. Appropriate dressing selection should be based on our holistic assessment of the wound. Wound speaks language, so you need to understand the particular language the wound is speaking. Looking at the present to be able to. I want us to note that no one dressing can offer everything the wound may need at a particular time. There are various choices of dressing. You need to know the language that wound is speaking to be able to assess and give what the wound needs, then the wound will heal. We have a preliminary assessment before dressing. You want to look at the level of consciousness of the patient. You want to understand your patient, does it have pain? The vital signs of the patient can stand the stress of the procedure. Is the patient having allergy to tape or any other solution? Is there any bleeding tendency? Like our gauze dressing, sometimes for our post-op wounds. If you are not very careful, the patient may tend to bleed. You want to also look at the doctor's order concerning that wound change. You want to see the drainage. Is it serous-sanguineous? Is it purulent? These are things we need to consider. The condition of the wound itself. And under the preparation, it is very, very important to ensure the wound hygiene is ensured. Sweeping, mopping, eye dusting to prevent the spread of infection. You need to explain the procedure to the patient to gain consent. You need to gather all your materials and assemble them at the bedside. Your lighting should be appropriate because if you need to remove stitches or staples, you must have good illumination. You need to switch off your fan. It is better with AC, but if your fan is on, you cannot afford that, then it has to be switched off for the procedure. You provide privacy by using screen. And then you also need to check the agency protocol, where appropriate, and the cleansing solutions you may need from your assessment to the wound. You need to position your disposable bag. Sometimes we may have the red Bowser bag. We may lose the pega bin. Some has to be positioned, and then they have to be placed in reach for soil dressing. You have this picture is a 6-year-old training, bringing in the modern methods of dressing by a German product, Protosan, to our hospital. Because there is a traditional way we've been doing dressing. And in the 21st century, the story of wound management has changed drastically. And there is a great improvement with the modern methods. So this afternoon, we'll be looking at some of them, how we could use them to achieve success story in the procedure of dressing. The following checklist can also be helpful in selecting appropriate wound dressing material. Most of the time, wound heal better in a moist environment. You need to consider what you want to achieve. Is it for autolytic property? Is it for bacteria proof when you're talking about wound bed preparation biofilms? Are you promoting granulation? Are you looking at the cost effectiveness? I have a patient that was managed in a rural DM patient, and they told him to bring 2 hen, 2 goats, and then 2 ram for them to make some concussions to be rubbed on the wound. Unfortunately, after 4 weeks, the wound became infected and he found himself to the hospital. To the glory of God, is better managed now and the wound is almost healed. It means the patient is doing very well. So these are things we need to consider. Although very, very important, like the first case report that was presented, to the patient, psychologically, it gives them a lot of problem. We need to consider all this before going to the procedure. Types of dressing. We are transparent in the modern types of dressing. We have transparent adhesive film, hydrocolloids, like I've been mentioned, collagen, hydros. We have Protosan. We have a exobate absorbent like Keramines. These are foams, Gamgee, to absorb exudate. We have lubricating spray like upside spray. They are very good in our post-op wound. We have enzymatic debriders and non-adhesive dressing. And our old traditional gauze dressing is still there. It's not obsolete to some wound. In selecting the appropriate wound dressing, we may need this assessment scale to guide us in picking or choosing that dressing material. The stage of the wound. Is the wound, definitely you will know the wound will need a debridement, either surgical or mechanical. We use Maggot. If the wound is slothy, we need to deslough. Depending on the depth of the wound, we may need hydrogel at low exudate. If it's high, we may need additive foams. We also need to see if it is granulating tissue that we need, where you see pink and then red superficial wounds, then we need agents that will promote wound healing. Protosan come up, hydrogels will come up in this level. And finally, if it is epithelializing wound granulating, we also need or film, and also And hypergranulation that may later leads to burning the wound, bringing silver impregnated substance. We have this summary table, the principle in preparing for optimum wound healing, telling us the characteristics of the wound, products to be used, and the goals to be achieved. Is a teach to debride. That's the goal we want to achieve. If it is infection, we can bring in article bacteriographs, balance, and prevent inflammation. When we're looking at moisture, then definitely Primapol would be good to use to maintain moisture balance. And if it's the wound edge, we have wounds that can be booked for secondary closure with Steri-Strip. We can do advanced closure without going to the theater. The principle of wound dressing must be kept. The use of standard precautions at all times. A lot of our patients, they may say that because they have said water will not touch the wound, they had CX, they are discharged after 5, the next 2 months, they will not. And then the materials used for the dressing, they are not sterile. This will not. That precautions must be considered at all times. Performing a hand hygiene, the use of gloves, even surgical gloves in doing the cleaning, it reduces pain. Management also has to be considered. And when we use our swabs, we use our swab once in, out, each time. You can't use a swab and then biofilms back to the wound, it will reinfect the wound. When we do irrigations, we start from the cleanest to the lower part. The temperature of the fluid we are using for irrigation must be room temperature so that it will not cause other complications to the patient. And we allow our irrigants to flow from the cleanest area to the contaminated area to prevent the spread of pathogens. The duration of dressing. Healthcare professionals should select exactly the right dressing for each dressing. Too frequent dressings change should not be encouraged. You have a post-op wound, if not that the wound has maximum, you could leave it 2 days, and that's where Primapol comes in. These transparent films give you the wound assessment. Also, dressing should not be left for too long to avoid wound beds being waterlogged or too dry. It's important to note that dressing will need changing more often at the early stage, like the first case presentation. Oozing, draining pulse, foul smell, odor, definitely you need to do a lot of irrigation for using the bowel body. Also, your wound heals advantage when you choose the right dressing. And we should remember that the wound should be kept in a moist environment. The current trend in wound dressing is important to state that we have 2 classes of dressing materials. Classification can be passive or interactive. When we have passive dressings, they are just simple products like your gauze dressing. It doesn't have any interaction with the wound, no that protect, cover the wound. But most modern products are interactive. They have something to do with the wound bed to provide optimal environment at the wound dressing interface. It's also important to say that multidisciplinary and holistic approach to wound dressing cannot be overemphasized. I also summarize with this table the time principle. of choosing the appropriate dressing materials to prepare the wound bed for optimal healing. We need to address the patient issue.
Okay. You seem to have lost Mrs. Babalola for a second. We'll try and get her back. And I don't think she realizes she's frozen.
The patient should also be, the environment of the patient should be considered. Then,
Mrs. Babalola, just go back for us 1 or 2 sentences. You were frozen, and just unmute yourself, please. Just unmute yourself, please. That's it. Go ahead.
excuse me.
Yes, we can hear you now. Go ahead.
On the wound, in some of our patients, they have some psychological issue, like somebody bringing up a wound that is discharging. I have seen patients that has live maggot coming out of their wound from neglect. The environmental factors should be looked into. Time principle, we can also like organ. These are issues that might delay to counsel the patient to be patient and then give the right appropriate choice of care to ensure optimal healing. Under the time principle, we may look at the tissue. Are they viable under your assessment? Is the wound infected? Are they inflamed? Are they exudating? Is it high or low? Epithelialization. This will guide us in choosing the choices of drugs to use. Delay wound healing. There are varieties of factors that will impede wound healing. We have intrinsic factors, we have extrinsic factors like nutrition, fluid. We have local factors like edema, pH, wound healing. These factors should be given consideration because they may delay our wounds from healing. Wound healing is to ensure adequate granulated tissue being developed, contamination of the wound, because of the environment. We want to decrease the exudate, the purulent drainage. Most times when I handle very chronic wounds and the patient comes in with psychological stress, I tell them within 3 days, I'll put a smile in your face. And what do? We ensure getting maybe activated charcoal, and with good irrigation, within the next 3 dressings, the whole huddle goes off. And then ensuring that they are sterile. And ensuring also we have absorbent gauze, like Kerames, like Gamgee, to absorb the exudate. Some will be draining out, dripping exudate, and they would say they shouldn't cover it. so that it will heal faster. No. So it's poor management. We also need to provide moist environment, not too dry, not too wet, because wet environment also facilitates the multiplication of microorganisms. We need to apply medications to the wound. We also need to provide comfort when we dress wound. These are the roles of dressing in wound healing. Finally, it promotes aesthetic sense of humor to the patient. It is very, very important that we talk about lotions for dressings. We have normal saline, povidone iodine, dress lotion, dress powder, ointments, protosan, irrigating fluid, protosan gel, intrasite, aerosol, Cortimate. We have Askina, Cagitrol, Brunavidon, Mebo, Quarium, Patilin. As some of the available modern products we have here. But there is no magic dressing. Dressing is one aspect, treating the underlying condition. In summary, manage and all must be wound friendly to be able to accept our patients feel psychological, the sense of belonging. And most of the time that does not assist us in optimal wound healing. Give out this information that we must be gentle, we must show empathy, we must be compassionate, and then make use of the available materials that are within our reach to manage this patient's wound. Thank you for listening.
Thank you so much, Mrs. Babalola. Bumi, do we have any questions for Mrs. Babalola that we can put across? And indeed, any of the experts, Dr. Herrera can also contribute, and Mrs. Lawal if she's back online. Any question? If you have any questions for her, just raise your hand. Mrs. Babalola, I think to help with the internet, just switch off your video.
Okay.
Yeah, that should help us. Okay, Abiodun, go ahead.
Thank you, the chief host. I want to commend Mrs. Babalola because she's doing what she knows how to do best. So my question for her, I've typed and sent into the chat room, but I can still repeat
yes, please.
it. Yes. If there is a big wound with a long depth, is it advisable one use a sterile gloved hand to do the dressing, or there are long dressing forceps? That is my question for the presenter. Yes, ma'am. Thank you.
All right, Mrs. Yeah.
Wounds with cavity,
Mrs. Babalola, put off your video to help the internet while you're answering. You can just have your video off. So that will help you. And then you just carry on talking. We can hear you. Yeah, that's it. Go ahead. Yes, we can.
Have wounds that has advisable a long forceps if you can afford, stick. But most of the time, I prefer
all right, Mrs. Babalola, you're breaking.
Sterile orange stick.
You're breaking, Mrs. Babalola. You're going to have to start again.
I'm not getting an answer very well.
Yes, that's what I'm just trying to let her know. So please, could you
network? I'll come up again.
Yes, please. Dr. Herrera, do you have anything you want to contribute to that question, perhaps? while she logs back in.
Okay, thank you very much. Well done, Mrs. Babalola, for your presentation. It was short and really to the point. First of all, can I just ask her that if you're having issues with your network, you can also try to type your answer on the chat. That might also help. In case you still have issues. All right. But to the question, well, if it's a cavity, if it's a deep wound, I would say if you can get long forceps, it might help you. The only problem with forceps, tissue forceps, is that sometimes if you can't handle the pressure, because you might now go and do more damage than you plan to. Yes. So that's the only problem with it. But if it's a deep cavity, you're using your, no matter how nice you have your surgical gloves on and all of that, you just may not be able to get to real wound cleansing. And that's where irrigation really comes in. So sometimes we also encourage that you can get, if you get some of those very like 20 mil or even more syringes, and give yourself some good pressure. If you don't have the pressure syringes, so that can do some cavity work for you. But having said so, I mean, to your question, if you are going to use long forceps for wound care and wound cleaning, you have to be careful so that you don't do much more damage than good. Yes, so don't traumatize the wound. I think Mrs. Babalola may have wanted to say, but I suspect that that's what she wants to say, because that's the proper thing to do.
Yeah. Thank you. That was why I was also saying, depending on the depth of that cavity.
Exactly.
We use a sterile orange stick to roll through the sterile gauze and then go in for cleansing. And like you rightly said, irrigating first before cleansing. You can irrigate to clear before cleansing.
So just to add to that again, I'm not sure, I'm trying to look at the person who asked. So you know that the orange sticks, for those of you who know what an orange stick is, it actually has two ends, and one end of it is sharper, because we use the orange sticks to do other things even in the clinic. So it is the blunt end that you want to have the gauze wrapped round, so that you are not going traumatizing again. It's very important to not traumatize tissue that you're trying to help heal. Very, very important, okay? So just to put it out there. Any other question?
I also want to add that when we have cavities like that, from experience, we've had several wounds. We've used some of these modern products on. Within 10 days, the cavity feels hot. Once it is cleansed, and then you apply this like a perforated typhoid, and within 10 days, granulated tissue came up. I've also had a case of a burst abdomen, one of a breakdown CX. So, but like you said, cleansing, irrigation first, and then we introduce these products, and we don't do the dressing frequently.
Very good. That's a very important
we leave
thing.
it 3-4 days. Like asking 3-4 days.
So that's important to that's important, Mrs. Babala. That's the idea of not overly dressing a wound. I think that's extremely important for us to emphasize. Having said so, the caveat to it is that if your wound gets dirty, you can't say Mrs. Babalola and Dr. Trufanowi said, no, don't dress the wound until after 3-4 days.
No.
Exactly. So if you have a wound that is actually very active and doing much, you have to dress the wound. You have to change your dressing. One more thing again. I know you may have all have heard her speaking about alginate and some people will say some highfalutin dressings that may not be available. If you notice in her presentation, she did mention and she still put down gauze, i.e. sterile gauze for dressing. So if we don't have in your practice, you don't have any of all the branded names. By the way, Mrs. Babala, is anybody giving you any money for all the brands that you were bringing out? I said, is anybody giving you any money? Is any company giving you any money? Because you are giving out some brand names of wound dressings and stuff.
Been using their products.
I know. I know, but you know, usually, well, at least for us, if we're talking along the lines of all these things, we're very careful not to
Yeah.
give brand names, you know, so
Yeah.
that for the real, so apart from the fact that disclosure and all of that, the
Yeah.
real issue for me is, as much as possible, go generic as opposed to
Yeah.
branded, because your audience may just not be able to get at those products, and then they will
Yes.
think that there is nothing they can do.
Yeah.
So if you notice, every time she says it, she will give you what it is, and then she's just telling you that this is what they do. So yeah, you hear Private Pore, you hear 3M, you hear this. What can you get at? So look at the contents of these products. Luckily, Google is your friend. Everybody can check at this. And of course, you can always go back to this presentation and see
Yeah.
what is the active thing in all of these things. The importance of moist dressing cannot be overemphasized.
Yeah.
Importance of moist dressings cannot be overemphasized. I don't know if anybody heard Mrs. Babala say that you can clean wound or dress wound with methylated spirit. I don't think anybody heard that.
No.
It's important for us to stress that. I would really, okay, in fact, Ms. Flora, I'm saying somebody said in a community setting, can one sanitize the latex glove with methylated spirit to dress the wound? Mrs. Babala, what are your thoughts on that question?
Can I hear you again?
So let me read out the question for you. So someone is asking that in a community setting, can one sanitize the latex gloves with methylated spirit to dress wounds?
In the community setting?
Yes, that's the question. Mrs. Mojisola Maitani asking.
Well, in the absence of none, surgical glove, your latex glove that is sanitized with spirit goes a long way in removing soil dressing and then coming up with surgical gloves to dress the wound. If you cannot afford instruments that will be autoclaved or boiled, because you can't boil the latex glove. I know in the 30s, okay, in the 80s, where I trained as a midwife, we will use our bare hands to take delivery, but we can't try that now. The risk of infection is higher. So latex glove with spirit is as good as a clean glove that will be used to remove, to prevent contaminating the wound further. And then your surgical gloves, they are available, can be used to dress the wound to maintain aseptic technique. This is the standard I will give. Thank you.
So my question to that, Mrs. Babalola, if you think about it, so the question is, can one sanitize the latest gloves with methylated spirit? So if it's about sanitizing, that means you don't think that the glove you're using is clean. It's not coming from a pack. I don't know. Legisla, is that your question? Because if you have spirit,
no, she's using latest glove
in place of surgical gloves.
glove. That's what she's saying. She's using.
Mojisola, can you unmute yourself and clarify your question if you're here? I know you are here. Just raise your hand so I can see you so you can unmute. Okay, go ahead, Mojisola. Just unmute yourself.
Okay, thank you.
Yeah.
My question is, in a community setting or in a situation where probably the patients cannot afford surgical gloves and there is no instrument to dress the wound, can one use just sanitize with methylated spirits to dress the wound instead of using just the latest glove or burden the patient more by telling the patients to get
okay, I hear your
gloves?
questions.
Because in some cases, you even as nurses, we even buy the products that we use, everything for the patient because the patient cannot afford it.
Yes, that definitely gets that. So your worry now, Mojisola, is it the wound you are worried about in terms of the methylated spirit, or your gloves, that the gloves should be clean? I just want to be sure. Is it the wound? You know how we say don't use methylated spirit on open wound? So not to contaminate the wound
just,
further.
Yes, to sanitize the gloved hand before touching the wound.
Well, technically speaking, if you wash it very nice and clean, it's fine. That's the truth. But I think it's actually also good for your psyche that you've used some methylated spirits, which is as good as maybe using dilute bleach to sanitize or clean, disinfect your instruments. Yes, so sure, yes. My only problem with using methylated spirit to that is that you might actually compromise the integrity of the glove. So you send in things to affect yourself. So in one breath, you're trying to solve a problem, i.e. not infect the patient or worsen it. But next thing, you're getting yourself into some sort of compromise, because spirit is harsh and it can actually affect the quality and the integrity of that glove. So it might break the glove and you can't see it. Next thing, you will breach yourself. You are going in there thinking that you're helping, and then you've given yourself an issue. So that's where the problem is. This is why I said I wanted to be sure what you were asking. Okay? So it might be better for you to just be as clean as possible as you can be. Or if you think that you're not sure whether you've compromised yourself, because we're being as practical as possible, and I'm very happy you asked that question. If you do use the methylated spirit on that glove, maybe you should double glove. I think that might be the better thing to do. Double glove, because that way, just like when you double glove, sometimes it's difficult for you to really maneuver, especially if you have some skilled things you want to do with your hands. Yes? So that's it. I hope that helps. I hope that helps.
It does. Thank you.
Thank you. If you have a question, please raise your hand. Adiola, just raise your hand so I can see where you are and ask your question, please. And then the next person will be Josephine. All right, Josephine is ready. So go ahead, Josephine.
Can't I send it to you?
Go ahead, Josephine. Unmute yourself. Josephine, you were here a second ago. Okay, Adiola, do you want to ask your question? If you're not ready. Okay, let me read Adiola's question. She says, is all the dressing materials Mrs. Babala mentioned, are they readily available in Nigeria, and are they cost effective? That's Adiola's question. Are the dressing materials readily available in Nigeria, and are they cost effective?
Mrs. B, that's your question.
Hello?
Yes, go ahead. Yeah.
Some of these materials are available with the presentation from Professor Adejumo, a book, Untitled Approach to Wound Care. We have 6,000 products in managing wounds. So some of these products are available, and they're available in the country. We all just need to tap into the Hello?
Yes, we can hear you.
Okay. I was just saying that some of the products are available. A lot of them are available there in Lagos. We have the various brand unique glove with big brand products. We have Smith and Nephew. They are there available. Some of these products, they are available. But like you said, the issue of costs with our low resource end here, some of our patients cannot afford these products. That is the truth that cannot be overemphasized. I've just dressed a patient this morning. He came lamenting he has not eaten. It's definitely you have to feed the patient, you will give something. So they want you to provide those products. It's like a voluntary service. And without using those products, you cannot get results. So there is a lot of advocacy for us asking that these products are subsidized. Like Protosan has been in existence over 100 years from history that I was told. Intrasite over 35 years from history. So these products are available, but we end up not making use of them. Dress is the cheapest. They are available. We have the rep available to distribute these products to us. But I just think there is just a gap between the knowledge and the practice, that a training like this will assist us to bridge that gap. More people to know what can assist us to heal wound better, and then giving it a try is more of evidence-based, using it on their patients and then getting results.
Thank you, Mrs. Babalala, for that. We have another question from Josephine. Josephine is asking, what products are best for dressing an open diabetic foot with slough and exposed tendons?
Okay.
That doesn't sound like a simple answer. Go ahead.
From my experience on the field over 30 years, and with this modern product the last 7 years, Bronavidon has done a lot of tremendous work in the success story to diabetic foot. Bronavidon is a combination of povidone, 10% povidone. It's made from Germany, and it has given us a good success story. But it is also important that we take care of the blood sugar. I have a patient that the lymph was savage. Maybe I'm going to the next section already. The woman got to know she's diabetic on the sick bed. She was on Okada traveling, and she had a burns on the wound on the leg. Within 7 days, did not heal and became extensive and became sick because of what she applied to it. It was after 8 weeks on the sick bed, they detected she's diabetic. So the blood sugar, their diet. I have one of them that will always go for cucumber, will always go for pineapple. Pineapple is not the best because it's sweet. So if the sugar level is not controlled, then the wound might not heal. So apart from the fact that we have introduced Bronavidon, we have to consider other comorbid condition of the patient. And wound swabs that is done, we need to also step up the antibiotics the patient. 1 or 2 of them have to go for imipenem before we could be able to combat infection. So those local things, they also apply to the wound, infect the wound the more. So we need to stop local agents that is being introduced. Sometimes you dress a wound, the patient will come with their local concussions to rub it topically on the wound. That is what we face here in Africa. Thinking they've done something that they want to use to improve or to facilitate the wound. The nurse needs all the skills to be able to observe critically the stages of the wound and the improvement. And the hygiene is also very, very important.
Thank you. Thank you. Dr. Rere, do you want to add anything to that?
Well, Mrs. Babala has, before I speak, I think some people are still talking. Some people have their hands raised. You want to take, there's Abiola, just let's.
All right, Blessing was, yeah, let's Blessing go ahead because she asked me in the chat. So okay. Blessing, ask your question as well. Just unmute yourself.
Okay. Yeah. Okay, well done, ma, for the presentation. My question is, what's the best solution for CS incision breakdown? What solution can we use?
All right. Who's taking that?
Hello?
Yes, we can hear you.
Yeah, from your question, it depends on the stage of the breakdown of that wound. I have this patient that has a wound breakdown, CS breakdown, as far as Calabar. Just dress ointment did the magic. So it depends on the stage the wound is. Is it in stage 1, stage 2, or stage 3 involving deep cavity? So the first thing that you will assess, let's see the stage the wound is from your assessment. Is it discharging So there is no one magic product I want to give to you. You want to look at the stage the wound is. If it is discharging, then you know you want to clear off those exudate first, you irrigate, and then you put dress, which is the simplest. From even your simple povidone dress lotion, you can CS wound. But I've also seen CS wound that have broken down that we need to go as silver impregnated solution to be able to serve as antiseptic to remove biofilms and then infection before we can talk about healing. So it depends on the stage the wound is and then the appearance at your assessment. But as simple as dress solution, povidone, will do the job. And I also, maybe for cosmetic reason, we may need to say this, most of our CS patients too, we need to introduce things that will prevent scar formation. If there are patients that are liable to forming keloids, your silicone gel is available. It has done a lot of tremendous work for patients post-surgery. After 2 weeks, the wound has healed completely. You can apply the gel within 10 days. The whole scar hand disappears. So as simple as dress, and then I've also used Protosan, the haze granulated tissue. They will do the needful. I would say the minutes allocated for this training might not give all we will need. But from my wealth of experience, I've been able to package a handbook that says practical handbook on modern techniques in wound care. And we have a lot of examples. I even have a CS wound that had wound dehiscence, and it became a third degree. At that level, we need to take it stage by stage. So if I cannot give all the solutions, this handbook will go a long way to be able to express my experience on the field over the last 30 years. My phone number and my contact email is there. We will also be able to interact. And in the last 3 weeks, we've been able to inaugurate a wound care association in Nigeria, which we are taking off from Ile-Ife. You can get contact to us to be together so that we can work to serve our patients better.
Yes, we'll give details about that later towards the end. Thank you, Mrs. Babalola. All right, okay, Abiola, go ahead. Continue. You have your hand raised. Go ahead. Yeah.
Thank you, Mrs. Babalola.
Thank you for your patience. Go ahead.
Thank you, ma'am. I have like a few questions from the lotions she showed us for wound dressing. I know quite a few: non-saline, povidone iodine. I've used Protosan gel and the liquid for a patient before. Then we have a patient in our unit that comes, I think he's an elderly man. He's been carrying the wound for almost going to 8 years. And I've remembered on a few occasions, I've advised him that we should not do the wound dressings daily. But he refuses bluntly that he won't listen to nurses unless the doctor tells him otherwise. So I don't know what can be done. We have like 2 of them for years, over 5 years. We've been dressing the wound with little or no changes. So those are my few questions. Thank you.
Thank you. It is very important that we diagnose from the initial acute and chronic wound. Like the wound you have just, we may need to also assess to see what is the stage the wound is, what have been used. If there is no improvement, like I said, there is no magic product, you change to another product. But like I tell you, most of our people, they use the traditional methods. Some even use Dunhill on the wound, and when they come to you, they put something different. Now, depending on the stage the wound is, if it's a nurse practitioner managing that wound, You may need to also differentiate, is it an arterial ulcer or a venous ulcer? It might just be a compression bandage that the patient needs together with the wound dressing that will do the magic. I have one I'm managing presently. He has done skin grafting twice, and yet the wound has not closed up completely, just because each time he travels to the community, he gets the wound infected again, maybe because of cost, he cannot afford alternate days dressing, and the whole thing becomes something else. The last time he went with compression for 7 days, and by the time he came out, it was live maggot. But to the glory of God, with consistency is better. So we need to check for consistency, the stage of the wound for chronic wounds like that. And then the agents we are using. Some of these agents, they can also cause irritation to this wound, and they extend the wound if they react, even to plaster. I know of a patient that is using honey, is also using hydrogen peroxide. Honey has a little composition of hydrogen peroxide, if you check the literature. So we look at the composition of what this patient is using, and if it's not improving within 2 weeks, you need to change. And with good wound assessment, if it's a leg ulcer, you may need to do Doppler ultrasound to check the blood supply to that area. You check the nutrition. And so, like I've said, it's a teamwork in managing a wound. No single healthcare provider is an island when it comes to wound management, because it takes a holistic team to care for wound. And that multidisciplinary approach should not be ruled out. That patient may need to come and do a wound swab. You may need to see a plastic surgeon to assess the state of the wound. Is it healthy enough to prepare the patient for grafting? Because if there's extent much, it may take too longer time to close. So skin grafting might be the option. These are things we need to consider when we manage chronic patients.
Thank you. Thank you. We have another question from Francis about lotions again. What should be considered in making the choice of best lotion for a particular wound?
Hello?
Hello, did you hear me?
Please come off again.
So the question is, what should be considered in making the choice of best lotion to use for a particular wound?
Okay, I think I also said that for any wound to heal, you look at the wound bed preparation. It's like you are preparing a balanced diet that is attractive to someone. You need to put all the ingredients, okay, to make that delicacy complete. So your time principle will tell you what you need that will guide you to the lotions to use. So if I go back to that table, that will be healthy. Is it tissue or the wound edge? It needs a position. This will guide you, but it starts from the simplest, povidone, dress, and what you want to achieve. If it's infection, you want to debride, then you start advancing in that order. And we're not saying honey is even obsolete, but I say raw honey. The raw honey, there is a medi-honey that is the actual honey that is very good. And even when you use it, it is alternate days dressing. And even our natural honey to the raw honey, not the local ones that they've added other things to, does tremendous work to some wounds, not all wounds. And because we find out that virtually in the community, every wound is to go and use honey. No, it depends on the stage that wound is.
Thank you, Mrs. Bablo. I hope that answered your question. Now we have a question from Mr. Moto Ibo, if he's still online.
He's online.
Okay. And the question is, which of the agents among the ones you highlighted earlier enhance the vascularization of tissue? Just unmute yourself, and answer.
Okay, thank you, ma'am. One of the things that aids vascularization is wound debridement, meaning that when a wound is slothy, with scars, One of the things it impedes is so one of the things that it impedes is actually proper vascularization. Well debrided, which we can use different agents for instance, an hydrogel. I precisely mentioned protein gel then. It removes the slothy or the sloths and then gives an enabling environment for granulation, wound healing, and of course, proper vascularization. So an hydrogel, removing the sloths, the sloughing or removing the eschar will actually help to bring about an healthy wound environment and precisely helps in the vascularization. So an hydrogel will do that job, particularly in a wound that is quite sloughy or filled with eschar. So for that particular case that we presented, a protozoan gel which we used, helped in helped in the sloughing. And how it works is it helps in dissolving the sloughs and providing a moist environment. So it's a dual thing. The hydrogel works by disloughing and also providing a moist wound environment, which eventually helps with wound healing. And of course, help with vascularization as well. Thank you.
Thank you. All right, that's great. Dr. Irere, could you just handle the 3 questions that just popped up in the chat? One from is it Dauda, I think? If you could do those ones for me. You're on mute. Dauda is asking about radiotherapy, wounds caused by radiotherapy.
Okay.
Yeah.
Okay, so well, radiotherapy induced burn. So the thing is, more often than not, you have almost like what looks like a burn. They usually are almost like burns, but it depends. So you can't. I think the point is not to think that radiotherapy wounds are just because it's radiotherapy. How exactly does the wound present? What is the wound? And you will take it up from there. Everything to do with wound care, you have to have. I mean, in wound care, you have to think in mind risk assessment. What exactly is the problem when you have that wound? What is going on there? What are you worried about? And you determine the goal of care that you want to do. Have an action plan and evaluate. In any wound from any cause, those principles always come in play. So saying that it is radiotherapy induced, meaning that, well, this person has a wound, it was from radiotherapy, person had radiation, is not in itself enough because there are many things. So you still have to have a holistic management from assessing that particular wound, whether it came from radiotherapy or from DM. I don't know if that makes sense. So it depends on what it is. What is the wound? What is the issue? You heard Mrs. Babala saying that there is no one perfect wound dressing. There's no eureka. There's no utopia in the matter. You put it all together and have a holistic thing. Is it a burn? If it's a burn, does it look like a 3rd-degree burn? Is it a 1st-degree burn in terms of radiotherapy? Is it an ulcer? Is it a deeper one? Is it a shallow one? What is going on with that wound? Yes, you know it is due to radiotherapy, but the wound in itself, what's the problem? Having said so, you can think of so many things. In radiotherapy, I know they usually will talk along the lines of hyperbaric oxygen therapy. That will come in depending on the stage of that wound. Mrs. Babala has said that. I'm reiterating it again. Every wound must be individualized in itself. And that individualization is not only with respect to the wound and the wound stage, but to the person who is suffering that wound. You have to think about what that person is going through. That's one. Before I go into the next question, I just wanted to quickly reiterate, I think it was Abiola who mentioned something about a patient who they've been managing for a wound. Ms. Babala said it's about team care. It's a team, multidisciplinary approach. Now, to you and to any other person who is having some similar problem, if a patient gives you that sort of issue, that in itself is a barrier to effective management. Not because you have done it poorly, but because the patient is not going to allow you to help the patient, so to speak. So if the patient is insisting that, oh, he wants to hear from a doctor, you can initiate a multidisciplinary team with the patients included and whichever doctor. And all of you sit together on the table or, well, virtual table. Nowadays, we do a lot of things virtually. And speak. Let the patient hear from whoever he or she was thinking was this, but you will bring in your own input because you are the one who has been caring for that patient primarily, obviously with maybe doctor's input back and forth. So nobody says that in a team care, is the doctor who must call it, or the surgeon who must call the team. Whoever is of most importance at that point in time can say, please, can we have a meeting of this thing? So that's it. You may have to call a team so that wound can be, in addition to all the other things that Mrs. Babalola said. One other thing which happens and which must be considered in almost all wound care, offloading. I will not put this as a little thing. A patient who is going in and out of the community coming to your dressing, you say you want to do the dressing every 3 days, but he's going in and out, or every 2 days, or every week. When he's not with you, you don't know what he or she is doing. And you'll be wondering that you use all the nice products you got from London, you got from America, you got from where, and it's not going. That patient is not allowing that wound or the limb or whatever area to rest. So it's not going to heal. It's as simple as that. So you can use all the most fantastic and expensive devices or lotions or dressings or adhesives, as the case may be, and it's not going to do much for you because the counseling of what you are doing, the patient hasn't actually got it. And that's one of the reasons why sometimes you admit a patient who is seemingly well, but has something that is just looking you in the face and disturbing. You say, okay, you know what, come in. I will limit your movement up and about so that if I give you 1 week or 2 weeks for this lower limb wound or upper limb wound to heal, it will heal. Then you can say I'm a magic worker, but all I did was to restrict your movement so that my work, yes. So as much as we are speaking all of this and going back and forth, we have to remember that our patients are very dynamic. We are thinking about the wound and thinking this is how the wound should behave. This is how the wound should behave. You have theoretized the wound, forgetting that the wound is not on a car. The wound is on a human being who has his or her own head, who has a deadline, who is thinking of the child's school fees, who is thinking of how he wants to sort out his or his mother's problem. And of course, he's going to move. If you don't restrict his movement, it's going to move. And if he moves, your dressing will not, your wound care will be ineffective in as, I don't know. So I'm just putting out that there. Flora, please let me see if I have more questions. I wanted to bring all of that out because I didn't want to.
You have questions. What's the place of blue stone in overgranulated wounds?
Mrs. Babalola, Bluestone.
Hello?
Okay. Can you hear me?
Hello?
Yes, what is the place of blue stone in an overgranulated wound?
Okay, it's used to burn the wound.
Yes.
Yes.
Kind of like to bring it down. So I'm
you just need to put it once.
On it, just on it.
Eh?
Yes, I'm agreeing with you. I'm trying to make use because this is your, I'm trying to make you speak.
The alternative to that is a silver nitrate stick. We have a silver nitrate stick that is used to also burn. It's instant.
My caveat.
However, what about the blue stone?
No, the blue stone, she has mentioned that the blue
is
stone
used in the community, yes.
Okay.
It does the same thing.
So the point for me, just a quick caveat, silver nitrate and silver dressings generally in dermatology, we are very careful.
Yes.
Because people can have quite severe allergic reactions to them. So in fact, I can tell you for free that we don't routinely use silver-based dressings, impregnated, topically applied, as much as possible. We don't. Because when you have very severe, dermatology, we have very few emergencies. But when we have them, it's a headache. You can be sitting there and people be wondering what's wrong with you. You are bathing for the patient. You are dressing for the patient. The doctor, the nurse, you don't sleep. Everybody is on ground. So whilst it does a lot of degranulation in a manner of speaking, you have to be very, very, very mindful of allergic reaction. So you should ask your questions and probably have it on a small area as a test site before you go ahead and do it for a larger area.
Sometimes you can dissolve it, you dilute it.
It's not necessarily the concentration. Allergic reactions, no. So just quickly bring in that. Allergic reaction is not a consequence of the load or the dose. If you're allergic to it, you're allergic to it.
Yeah.
Yes, so that's the thing. So what you want to do, if you're not certain, is to test dose in a small area and then see. And if the patient is not having a problem with it, then you can go ahead and use it. Or if your patient has a reason a patient had a history of an allergic reaction before, so it's your duty to ask about that. And then if they say they're not sure, do your test dose, but don't just go to town and use a silver pregnated dressing, whether topically applied or whatever, because you don't want to get into more trouble.
Yeah.
Okay.
Great. Thank you for highlighting that. That's very important. Allergic reactions. Okay, so you've mentioned about silver based dressings. Where does maggot therapy come in? That's another question. Where does maggot therapy come in? And where does it come in? And when should it be used?
Very dirty wounds.
Mrs. Babala, you want to take that? Go ahead and take
I was trying to say, maggot dressing comes in when you have very, very dirty wounds. Very dirty wound. And it's not just maggots.
It's not regular, exactly. It's medical maggots. Exactly.
It's cultured maggot. So at least for my hospital, we've not using it. I've only learned about it through study. We've not started in our hospital, but I learned one hospital. I've just brought it to Nigeria, and I'm trying to link up with them. But it's meant for dirty, very dirty dressings. Okay.
So the maggots are behaving like a bit of, they're doing some sort of autolysis. Yes, exactly. So autolytic sort of injury.
By the time you now go in to do your flushing irrigation, you
have less work to do. Yeah.
Wound bed preparation, you reduce the bacterial load, the biofilms. And that was why I was trying to remember the other time. Protosan has betaine and polyhexidine.
Yes, I was going to tell patients, everybody listening.
I remember that I wanted to.
Thank you. Yes.
And also I want to say, the person that asked the question for radiotherapy, from my experience on the field, I have seen people, maybe advanced cases that went for radiotherapy, they come with burns. Okay.
That's what I said.
Mebo has been very, very helpful. Mebo cream. Even as simple as dress cream, ointment does a little magic in healing such wound, because most of the time they are superficial.
Yeah. Well, so that's I would just give a little bit of a caveat. You are correct in saying Mebo and all of that, and I did mention that radiotherapy mostly are like burns. However, depending on the extent.
Yes,
depending.
I agree.
Yes, exactly.
I agree. If it is superficial, that is when those two. If not, go through the protocol of
of proper burn care. So if it's a small, if it's not a big deal, because Mebo is actually an acronym of MEBO, which is moist exposed burn ointment. So it's legally as if you're trying to treat a burn. But I had mentioned before that you cannot use a catch-all phrase or catch-all care because it's a radiotherapy based wound. You need to assess the wound and say what is the problem. Assess that wound and move on.
Assess and see the language the wound is speaking.
Exactly. So I was going to say, so Mrs. Babalola, that those my students, undergrad and postgrad, there's something I always say. I say, I need you all to speak skinese, which is the language of the skins. So everybody that says skinese, they say, okay, this is from Dr. Otrofanowe. And so when I saw your slide and you were saying the language of the wound, I'm like, okay, somebody's speaking my language here. We are
speaking of languages. So if the wound is speaking the language of being overgranulating, how do you manage it? Let me try and enter your.
But that's what we have said.
We have said it.
Yeah.
We mentioned it already.
Okay.
We mentioned it. Yes.
Okay, because someone was just asking again. So how do we manage an overgranulating wound? Okay, that's been answered. Fantastic. Francis, do you want to raise your hand and ask your question so I can see where you are, and then you can unmute yourself, Francis? Or you haven't left the building? You just responded to me. Where are you, Francis?
Mrs. Flora, the third presenter did not present.
Yes, we will discuss about that later. Okay, Francis.
It's 5.
Okay, let me ask Francis's question. He would like to, would like to get your opinion on routine care of a surgical wound to ensure quick healing and prevent breakdown and infection. So Francis wants to get our opinion on routine care of a surgical wound to ensure quick healing and prevent breakdown and infection.
Okay.
So what do we say to that?
Well, it's just to summarize the practical wound dressing that we have discussed. What are we doing right and what are we not doing well? Okay. For every surgical wound needs minimum touch. So the frequency of dressing comes in this time. If the patient is operated, first day post-operative wound, you don't need to open if it's not soiled with blood. So we can have alternate days dressing or thrice in a week or twice in a week. And it is better we bring in Primapor. Primapor is a sterile dressing that ensures moist environment to the wound. So minimum touch to the wound, that aseptic technique is very, very important. Most of the time we reinfect the wound through our continuous or frequent contact. So, and then also keeping the wound moist. But that's not to say we should be cleaning our wounds with our spirit. It dries up the skin. Dress, Povidone is better. So if we keep to those rules, most of the time, and good diet and rest for the patient, just like Dr. Herrera said, our wounds are likely to heal by first intention.
Great, thank you very much. Mrs. Lawal? Now, we had a few mentions about medication and appropriate use of medication in wound management. And yes, can you speak to that, please? Appropriate use of medication in wound management. Go ahead, Mrs. Lawal.
Okay. Yeah, a lot has been said, and even I've learned a lot from
Your internet is frozen. We can't hear you.
What we know
Okay,
is
go ahead.
things on wounds, and sadly, sometimes.
Okay, I think Mrs. Lawal's network is playing up. Dr. Herrera, is there anything you want to speak to that? Appropriate use of medicines in wound management? And Mrs. Babalola, please. I will just take that quickly before we go to the final sessions, please.
I think what I want, let me just emphasize, I'll give Mrs. Babalola
Internet
the
has been
floor.
bad today.
Okay, she's
Sometimes us use things like
She doesn't realize her internet is not clear.
powder, like.
So Herrera,
Hello?
go ahead. Herrera, go ahead. You're on mute now. You just muted yourself.
I think you should give Mrs. Babalola a chance to speak because she's trying again. So she did mention, just give her a chance.
Mrs. Lawal, you mean?
I'm sorry, Mrs. Lawal. Mrs. Lawal.
All right, Mrs. Lawal, try again, please.
Okay.
We didn't hear you at all.
I don't know what you heard because I didn't even know you didn't hear me.
Yes,
I was saying
just start again.
Okay, I was saying that some people use drugs like cocaine penicillin powder to dress wounds. Some people apply penicillin ointments, and we need to move from this kind of practice to the real one from what we have learned today. Because we all know that applying things like cocaine penicillin or penicillin ointments can sensitize the patient to allergies, and they're just not it. So in use of drugs for wounds, we need to carry the pharmacists along when we are in doubt, ask questions. That sometimes patients are placed arbitrarily on antibiotics for unjust reasons. And of course, we know that will be breeding, contributing a lot to antimicrobial resistance. So we need to promote rational use of drugs, even in wound management. And sometimes these patients are on some herbal products that might be interfering with the healing of the wounds themselves. So it's also good to know whatever the patient is using so that we can counsel appropriately. Well, like I said, a lot has been said today about wound management. And one of the questions that I probably would like to speak to, somebody was asking if we should have training for community pharmacists in basic management of wounds. And I think Encapsulate will look into this too, so that we can organize and have training for community pharmacists. We have not done so much in wound management. We need to do a lot more there, because usually we are the first point of call, and whatever we do can make or mar what happens next to the patient. So I'm looking forward to Encapsulate organizing a training for community pharmacists on our roles or whatever we should do when we see wound cases in the community setting. But most importantly, we should be all out for interference from drugs. And we've seen a number of patients, they take a lot of concussions about things. They won't tell that to the doctor managing, but we can get that information and work with the doctor to look at what is happening. Sometimes the doctor just thinks, oh, my patient is not responding. He doesn't know why the patient is not responding. We might be able to know why the patient is not responding, because the patient is also on some supplements or herbals that are interacting with or interrupting the management that is in place. So I think we have a lot to come up with there as community pharmacists. Thank you.
Thank you. I mean, following on from that question, just generally to the three of you, to the three panelists, what steps are in place or can be put in place to inform the public on proper wound care and seeking appropriate help early? Because I understand sometimes they present very late. So whoever wants to take that.
Hello?
Yes?
Yeah. In the 21st century, like I said, the issue of wound management has advanced greatly. So I think the first thing is to education, creating awareness. And then we have practitioners, healthcare providers, healthcare practitioners in their own domain, trying to enlighten and making our doorstep accessible. Like I have a domiciliary wound care services. Your patient should be able, those around you should be able to ask you, what should I do if I have such a problem? We should be approachable. And then tell them, you need to do this, the issue of aseptic technique, cleansing of the wound, the type of agent to use, they are very, very important. I remember in my 80s, I have a super nurse that we call him Super Solution. He makes Super Solution from Rocephin, as far back as that time, streptomycin, liquid paraffin, normal saline. He would dilute it, and that is what we use to dress wound. We call it Super Solution. And everybody will be wondering that within 2 weeks, the wound will heal. We've not been using Super Solution the last 10 years, and our wounds are healing. The success stories are there. So we need enlightenment of the community, those around us. Health care providers should be able to stand in that gap and recognize.
And that's why we're doing what we're doing today.
Yes, and that's why
part of
I want to appreciate Mrs. Flora and Heal the Wound initiative, because even what we are doing now, we are giving back to a lot of people that is trainers, and then they will retrain. People are being enlightened of things that are available that could give us better results in managing wound. I know of Cicatrine in the 80s. I don't know when last I've seen Cicatrine being used, because we discourage them. Even our CS wound in the past, you will see they will put GV. The last 10 years, I don't think I've seen a CS wound with GV. You understand? So there is advancement, and we need to preach the good news, tell the populace the available things that will give them better care, and then be able to assess medical help in time so that acute wounds don't become chronic. You know, there are beliefs that if you have surgery, you must not take your bath. In the course of my own training or practice, I have seen a lot. And I would tell my patient, go and clean up and come. I would clean up your wound will heal. And by the time they refresh, they come, they start thanking you as if you've done something really tremendous. That the last 2 months I've not taken my bath is because they said the wound will break down and it will not heal. So, and they are all false belief, misconception. We need to clear all this to ensure wound heal. Some will even say taking snail. In snail, there is calcium. I tell my patient to go for fruits. Pineapple that has bromelain will make wound to heal. But some will tell you, they have said, if I do this, even sex, the wound will not heal. It's as funny as that. So health education, starting from the community and then to our urban setting, putting up programs like this, training. And that's why we are looking at the association coming in to fill in the gap, because people are not even going to the specialization. That is the truth.
Thank you. Thank you, Mrs. Babalola. Dr. Irere, anything to add to that? Or should I go to the raised hand? Oh, Mrs. B has said it all.
I'm muted. Oh, okay. You had muted me before, so yeah. Well, she has spoken very well. She has spoken very well, and I think I'm just going off for what Mrs. Lawal also said about. In fact, Mrs. Lawal can probably give you a real life scenario of patients and what they had done to a wound, and when they came to me, and we're going back and forth, and that's how we kept opening our eyes. And we're like, oh my God, oh my God. And this is Lagos. This is urban. So you can imagine what is happening in the rural settings. If where they have access to more people, community pharmacies are everywhere, and they have a very strong association, the community pharmacies, and they're doing quite a lot. And yeah, we still have this. I think in addition to all that Mrs. Babalola has said, whether we like it or not, we have to push for regulations. She said something. She gave me cicatrine. She gave us gentian violent. She gave us the super concoction of what her nurse used to use. The truth of the matter is that if things are available to be used, they will be used. One of the problems we're having with the nicer modern dressings is we talk about poor availability or affordability, as the case may be. However, you see things like, so in some places, you haven't seen cicatrine because you are practicing in where everybody knows that cicatrine is not supposed to be used. You probably are not seeing GV, but there's some places that that's all they see. And it's because it's available. So if regulatory wise, those things are not available, only the things that are supposed to be used are available, then the people who want to use them poorly will not have them to use, and we can move on from there. This is, remember I'm saying that in addition to all you have said about education, health awareness, I mean, those days we grew up with a lot of jingles on the radio. Health is wealth, do this. I remember health is wealth, blah, 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 blah. We had all of those songs. We don't hear those things anymore. So people still don't know. Information, communication, effective communication, good information, effective communication, and dissemination of such information is very, very important. I think we don't have that. And it is, we think that this we're doing, in fact, Flora, we've done this how many years running? You'll be there thinking you've done a lot. You think it's a lot. It's literally like a drop in the bucket because there is so much out there that you have to combat. One of the points we had said to this particular training was, let's not be talking. Let's hear from the people that we have spoken to in the last few years and see, are we even making any impact? So it's one thing to say you are putting things out in the community, you're telling the people things. Another thing to actually assess what's the effect of what you're doing. Because otherwise you're just speaking to almost to the gallery. You can have a beautiful book like Mrs. Babalola has done, and people are not reading it, or they read it and they're like, I beg, this is highfalutin, Jerry, it's not for us. Come down to this level and let us see exactly what is going on. Then you will begin to see the changes. So they're not coming to the teaching hospital. They're not going to the specialist, you think, but they are going to many other people. And sometimes maybe the damage has been done way before you hear of it. And so you would be in your nice little cocoon of the tertiary center thinking this is all there is to it. And there is so much baggage going downwards.
Absolutely.
So apart from education, like you have rightly said, apart from dissemination of information, we need to look into regulation. So we also have to get into that policy making phase. That's extremely important.
Yes.
And it is from the grassroots. It's not, you don't wait till you are like high there before you, it's from the grassroots. Public health officials, the community health extension workers, the community health officers, all those people that are really are the, you know, they are the ones on ground. They feed you and you take it out there. So policies are extremely important. I just wanted to add that as well.
Thank you, Dr. Herrera. Totally agree with you 200%. And with you, Mrs. Babalola, absolutely. Galaxy Tab, thank you for your patience. Okay, this will be our last question because we need to move on to the last session. Galaxy Tab, are you ready? Unmute yourself for us, please, and then ask or tell us what your feedback is. Or have they gotten tired? Okay, there we go. Go ahead.
Yeah, I was just going to ask Sister Lawa, Mrs. Lawa, the pharmacist.
Yes.
What does she think about the use of vitamin C with wound to aid wound healing? Is this still much in practice? Vitamin C.
Okay, Mrs. Lawal, over to you.
Vitamin C is an antioxidant, and it wouldn't hurt, it wouldn't harm as long as it's not applied on the wound topically. So it's normal for patients to be given some supplements that might aid and make the body respond positively. So the important thing is that it shouldn't also be used excessively. Anything done excessively is bad. So vitamin C it's not what I'm scared of or worried about.
Okay. Thank you.
Thank you for that. Okay, so we are going to move on to the next session. And while they're getting ready, I will just ask you to, I'm back again with my polo. Could you just do the poll, please, for Mrs. Babalola's session? Let's do that quickly while the presenters are getting ready for the next session. Can we all see the poll? Let's quickly do that. It's just going to take us 1 minute. Let's give feedback to Mrs. Babalola, please, for her presentation. That would be great if we can all answer that. I can't see anybody completing the poll. Thank you. Thank you. Let's quickly do that, please. Thank you. Thank you. So now we are going to talk about, while you're doing the poll, please just continue to fill that. Let's give the speakers 1 minute break while they get ready. Thank you. We're going to be talking about amputation as a complication of poor wound management. Can it be prevented? So we almost gave it away at the beginning before I had to pause. So we're going to be talking about amputation as a complication of poor wound management. Can it be prevented? So Mrs. Babalola is going to take this session along with her co-presenters, if they're also available. I think Mojisola, Mr. Motoyimbo, and Mr. Bikule will contribute. I don't know if they were part of that team that had a great outcome for the patient. Are we all done? Have we completed the survey for me? I'll just do it one more minute. I only have 8 people here. Please, I need at least 20 more people to give their feedback. I know you did it in the chat, but this will be good for her to see it visually. Quickly, please. Thank you. All right, if you guys are ready, just give me a thumbs up. We'll talk about amputation. Thank you. Give me a thumbs up when you're ready. Speakers, if you're ready, give me a thumbs up. And let's talk about this amputation complication of poor wound management.
Are we not taking myectomies case report
We may
again?
not have time for that. Let's do the amputation first, please. If you're ready, let me know.
It's okay.
I've only have 16 people do the poll. I need, please, can we get to 25 or 30? It takes literally 1 minute so that our speakers can know their impact on you today. Thank you. All righty. Okay. Okay. And then how did we find the Q&A as well? Let me know. Let's do that now quickly. Mrs. B, are you ready? Is Mr. Motoibo ready? Is Mr. Ibikuli ready? How did we find the Q&A? Let me know. The discussions, answers to your questions. Is Mrs. Babalola ready? Yeah, keep responding for me while they're getting ready. Just 1 more 2 minutes. I think her internet has gone off, so let's just do this anyway. Thank you. Thank you. Thank you. I need 20 more people to give their feedback. Literally takes a minute. And if you have any other comment or feedback that you cannot type in the poll, just send me a direct message. Any other thing you want to highlight that we can do better, or any other comment of what we did well and anything we can do better. And also let me know what topics you would like us to cover in the future. That would be great, so that we can put that together for you, because it's all about what serving you and your needs to improve your skills. So there's no point in us doing things that will not help you. So send me a direct message as well, or you can send me an email. The email is in the chat of what you'd like us to cover in the future. And if you'd like the recording or the slides, I'm going to take permission from the presenters. Just send an email as well. I've posted that quite a few times in the chat, so you can send me an email. I will get the link of the recording to you. All right, thank you, everybody. All righty, Mrs. Babalola, we're ready for you. But I don't know where she's gone. I think her internet. Ojisola, are you ready? Can you share your case study while we're waiting? You're ready?
Yeah.
Yes, Mr. Moto, you're getting my attention. Is Mrs. Babalola ready? Are we ready? Yeah, I can hear you.
She's having an issue with her network. She will join us from here.
All right, that's fine. Okay, let's go over to her.
It's a difficult fit to gigs. Hello? Hello?
Yes, we can hear you. You can share now, so go ahead. So we're talking about amputation as a complication of poor wound management. Can it be prevented? So
Yeah.
Mrs. Babalola is going to present the case along with
Okay.
co-presenter.
Please give me 2 minutes.
All right, 2 minutes.
She'll be back on in less than a minute. Sorry, she's trying to solve an issue.
All righty. So as I was saying, yes, if there are any topics you would like us to cover, send me an email. I'll pop it again in the chat. We will soon finish, but I really want you to hear this case study. It's a great example of when wound management is done well, what can be achieved. Okay. Mr. Bikunle, I can't see you. I need to see you. Raise your hand so I can find you easily so that you can unmute yourself. Okay, I can see you now. Go ahead. Did you want to make a comment, Mr. Bikunle?
Yes, I was just trying to come in while Ms. Babala is trying to get ourselves ready
Okay.
concerning prevention of amputation. So I don't know if you are ready for that now or until she comes up.
Yeah, so you were part of the team, I take it. Were you part of the team?
Oh, yes.
Okay, so you can start with the
we
background.
can
Start with the
actually
background.
prevent amputation.
Okay, start with the
Amputation
background for that patient. Start with the background and so that everybody's up to speed.
Okay. Amputation is a removal of parts of the body surgically or traumatically, either by accident or surgically. So either ways, amputation could be done intentionally or unintentionally. So, and most times it happens to all the extremities, I mean the upper limbs and the lower limbs. So amputation as related to wound management could be prevented if there is early presentation of the wound of the patient in the hospital, and if proper management is given. There is one thing to present early. It is another thing to actually manage the patient appropriately. And this is prevention of amputation start from presentation. So when a patient presents, to a caregiver, maybe a doctor or a nurse, especially a patient with wound, it's proper, holistic assessment is needed, is germane at this point to know the stages of the stage of the wound, how far the wound has been, the age of the wound, and then, like she said, my consultant Ms. Babala said, wound speak. So what is he saying? What is the wound saying? And from there, the holistic assessment also boils down to assessing the whole patient, him or herself. You assess the patient, the chemistry, the laboratory investigation. All those things are important to help in wound healing. And when these things are done, that will lead the caregiver to proper planning of the wound management. So if you can't just jump into managing the wound without planning. So what are the things that we need to do? And all these things must be explained to the patient. The patient at this point is maybe depending on the site, and since we are discussing amputation, most likely it affects the upper limbs or the lower limbs. The patients are just immobility impaired, they are immobile, and maybe because of the wound. So their psychic is still okay. And then you need to carry the patient along as to what you've assessed and the management you are to render to such patients. So the patient is not left for a patient to decide on what to do. So most times the patient presents late, and the caregiver wouldn't have a choice than after run, one or two tests, the Doppler, and then it reveals the vessels are compromised, a vascular necrosis setting, and they wouldn't have a choice than to prevent accession of infection or and some other things that can further destroy or lead to mismanagement of such limbs. So they will prefer to quickly, remove such parts, amputate the limb in order to salvage the life of the patient. So most times, if patients present early in the hospital, amputations are preventable. That is what I have for now. I don't know, maybe.
Thank you very much, Mr. Ibikule. Thank you so much. That was perfect timing. Mrs. Babala is back on now. Thank you so much. So, Mrs. Babala, you can take over. Thank you so much.
So, can you recap?
He just went. Mr. Ebikule was just discussing amputation, the importance of presenting early, and so on. So you can go ahead and talk about your patient too, because we're running out of time now. So just go ahead.
Okay, well, optimal management of wounds goes beyond looking at the wound. The integration of both psychological, environmental, nutritional, and dimension to facilitate healing and recovery should be considered. The management of chronic wound like diabetic foot ulcer should be given a holistic approach. And that is what reporting early, that is what will give us an improved outcome. Salvaging limbs, at least I have 10 to the glory of God that we've been able to salvage. And at each stage, it has been an holistic approach, bringing in the plastic surgeon, bringing in nutritionists, bringing in the nurses, bringing in other healthcare practitioners to ensure we give the best to this patient. It is preventable. And I know with this multidisciplinary approach in wound management, we've worked as a team to salvage a lot of limbs. Even the hematologists, we bring them in. Some are transfused along the line, but the most important aspect of it, because nobody wants to lose any part of their body, we end up salvaging this limb. The patients are happy. We put smiles to their face. My submissions are the patient should report early, and then they shouldn't compromise. Compromise in the sense that it should be a total care. Once they submit themselves to the modern care, they shouldn't be bringing in traditional in between. They are truthful, they are upright to their care. Like the diabetic foods we manage, I know the patients were involved in them, even checking their blood sugar daily for about 2 weeks. There was one I and the Bicule managed, also 2 of them, I and the Moto Ibo managed. We were there for the routine blood check. Their personal hygiene is attended to. When they were depressed, even a psychologist was brought in. I remember when they brought in the orthopedic surgeon and they told the patient 50-50. The patient started crying. 50-50 means within 2 weeks, if it doesn't improve, we are going in to remove this leg so that you don't have a sudden infection and you die of sepsis. So it is very, very important that holistic approach, early intervention, and then the comprehensive care is given to this patient when they report to the hospital.
So, Mrs. Babalola, could you share the slide that Mr. Motoibo showed us earlier on about the case that the patient that the limb was actually saved and what you actually did, so that everyone can learn from what you guys did? You should be able to share, Mr. Motoibo.
All right, I'll do that now. Just a minute, please.
Okay. Once again, viewer advisory, there will be pictures of wounds from clinical settings, just to let you know. So if you are adverse to seeing those kind of pictures, this is just your warning in advance. I've given you permission to share, so you should be able to share.
Okay. Can you see it now?
No, yeah, it's come up. It's coming up. There we go. Yes.
Okay.
Yeah, carry on.
Okay.
So you did the first part. So now what did we do to save this person's limb? Because the session is on amputation and good quality wound management, saving a patient's limb. Go ahead.
Okay, thank you, ma'am. I'll just continue from where I stopped the last time. So the summary of what was done, I can summarize it with these charts. We have holistic wound assessment, wound diagnosis, and wound dressing. Many things have been said about this, each of the items. For instance, the holistic wound assessment, Ms. Babalola has done good justice to that, and the other co-presenters, where we need to examine the wound, not just from a perspective or a single perspective of, the wound itself, but looking at the patient holistically from the diet, from premorbid conditions and all that, which had been earlier mentioned, then which will lead us to the wound diagnosis. The wound diagnosis will mean what exactly is the type of this wound. This particular wound, we have said before now that it's infected, septic, offensive, poor wound healing prognosis, and also all that will lead us to the diagnosis of the wound, and which will lead us to the wound dressing. Which also we have mentioned before now, that involves a multidisciplinary approach involving the use of proper wound dressing agents, and also other factors are being brought into play. So in summary, in summary, from the assessment, we have seen pain, contributing factors like nutrition, medications, physiological characteristics, the size, the time. I won't dwell on this because all these have been mentioned before now. There's social concentrations. Those things have been earlier mentioned. So those are the things that are to be considered before then which will now determine the kind of dressing, which I will call the wound diagnosis, the kind of wound, and then the kind of dressing, which we have also mentioned before now, either hydrocolloids, alginate, hydrogels, foams, and antimicrobial. For this particular wound, for instance, we use an hydrogel, protosan gel, so an hydrogel, and also an antimicrobial, that's dress lotion, which we mentioned earlier before now as well. So in conclusion now, what I would just say to conclude this section is the fact that if you go back to this slide, you will see that this is an arrow, meaning that you don't just assess the wound and turn back. You have to continually go back and assess, and then meaning that the wound does not stay in one stage, just like Zambalo has said, that it's not, there's no magic dressing. You need to keep reassessing the wound, or we need to have the proper wound assessment, before we can actually arrive at the proper wound diagnosis and then wound dressing. So this will help us come from the perspective of, ensuring that we are not being ritualistic in our approach, which is actually what the practice is in many settings, where we are just ritualistic, just pick what we feel works or what has worked before now. But with holistic assessments, we are definitely going to come up with a good wound diagnosis, and then appropriate wound dressings will come into play, which eventually will help us have a good wound healing. So in this particular case, one thing I know we did well was for us to have a good wound assessment and we're able to bring out the problems with this patient beyond, just the wound, the nutrition, the environment, appropriate wound dressing agents and all that, which we have mentioned before now. And then that helped us to give a proper management, of the wound. And that proper management, like I said the other time, holistic management, which of course helped us to have a good prognosis in the healing. So in concluding, I would say that modern trends in wound dressing goes beyond just the selection of the right modern wound dressing agents. It actually involves an holistic perspective to wound care, meaning that you consider several other associated factors that could help us, assess or can help us, come up with a good wound prognosis beyond just the wound. And of course, the right use of modern wound dressing agents. Because these wound agents are much. Literature will say that we have over 3,000 of them. So it's vital for us to have, to select the right ones, which proper wound diagnosis will help us to do. And of course, which I earlier mentioned, observing principle of baby sepsis. All these were done to ensure that that limb was salvaged. Thank you very much.
Thank you very much, Mr. Motoibo and Mrs. Babalola and the team. That was great. And it's great to hear that, several patients also have had their limbs salvaged and prevented from being amputated because of good wound management and good wound care. Please stop sharing your screen, please. Mr. Amoptoimbo, stop sharing for me. Thank you. Okay. So unfortunately, we had one more case, but because of time, we have really run out of time. We're unable to share one more case with you. It's already been 3 hours, and I was trying to keep this to 2 hours, but we had a lot of interaction, and I hope a lot of your questions were answered. Do we have any questions in regards to the amputation? Any questions? Just raise your hands, or any, I can just take one more question or anything that has not been answered previously. No? Okay. While you're thinking of questions, could you just do my final poll for me regarding the whole program today? Don't go. We have Augustine who's raised their hands. I think they have a question. I will take that before we close. And we've got Josephine as well. So could you just complete this final poll for me on the program for today? That will encourage all those who have been helping us, our supporters as well. Feedback. That would be great. And please, I want everybody online. There's 41 people. I want us to get full maximum participation in this poll, please, before we take the last 2 questions and wrap up for today. Thank you. Yeah. It takes you just one minute, please. And don't forget, if there are any topics you want us to cover, send me an email, encapsulatehealth@gmail.com. And if you would like a copy of the recording or the slides as well, send me an email, so it's easier for me to respond. Okay. Please, can we get at least 30 more people to respond? We've only got 16. And we can take Augustine and Josephine's questions, please, before our experts have to go. Well, they're supposed to be going now, but they should just hold on for 1 more minute, please. Mrs. Babalala, could you please put in the chat your contact details and how people can get hold of your handbook? If you can just write that in the chat for them, so they'll be able to contact you to get the handbook. I've got 19 people have answered. Please, can we get to at least 30? Thank you. Just about the whole program, please. It's basically tick, 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 and you're done. I have 20. Can I have 10 more people to complete this for me, please, before I close the poll? Thank you. Thank you. Thank you. Let's keep going. Only 50% of us have completed. Let's keep going. If you don't give me feedback, I won't know what you want. All righty. Thank you. I'll end it now. So, Augustine, what's your question? Unmute yourself, please.
Okay. Thank you very much for the presentation. Very educative. So my question is, Mrs. Babalala, well done, and the other presenters. During the course of your practice, when you meet a patient who says he or she used herbs to manage their wounds, and they actually got very good results, what's your take about it? And then what do you advise them to do after achieving such a result? That's one. And then I want to ask, while doing the wound dressing, is there anything about doing wound MCS and managing with oral antibiotics? Thank you very much.
Did we get those questions? Please unmute, Mrs. Babalala. Did we get those questions?
Yes.
Okay.
The question on antibiotics.
Yes, please. Let's keep them short because I'm going to take Josephine's questions last, and then that's it.
When we do MCS, we encourage that. Once we sense there is infection, we do MCS, and we give the appropriate antibiotics. It's very helpful. It's part of the holistic care we are talking about. Now, for patients, maybe we come across that have used one traditional thing or the other. Most wounds, clean wounds, will heal with first intention within 10 days. But when they come up with chronic wound that they've applied one thing or the other, I have presently a patient I'm managing with the diabetic leg ulcer. He has gone to a herbalist that collected a lot of things from him. He could not even afford to buy all. He bought goats, he bought, and they were rubbing some black things on the leg. Yet the leg did not improve. He came out himself for medical care. So if their wound has healed, they won't come up to us to medical care. If what they've used has healed them up. Those ones that would have healed, maybe they are just superficial wounds that have healed by first intention. When you meet up chronic wounds, the concussions may not heal it all. One, the issue of sepsis is there. Okay? And then you also need to see the extent of the wound. How did it start? Some will tell you it just starts with a bite, and then it's now extending to 10, 20, 30 centimeters, staying 3-4 years. Then definitely what they've used for that wound has not worked. I have this final patient 2-3 weeks ago that reported. Thank God the sister is a medical practitioner. She was the one that linked up with another doctor, and then they got contact with me from a village. And by the time the lady will present, it was a leg ulcer cellulitis, but there was over 200 scarifications on the leg that they've done in the village that will heal that leg. And the thing was inflamed, hematoma all over, and with pain. The scars were there. And I did not fight them. I only said, what have you used? The husband said nothing. He just started small, and I said, no problem. I started cleaning. I did the hygiene first to flush with Savlon and water, and then brought in dress. And it was a close dressing because it has exposed the skin to infection, and the thing has odor. So when they come with their traditional method, we don't run them down. We only expose them to contaminants that whatever they've applied topically might have caused. And as much as we can, we flush those things off and then start the aseptic technique in applying our dressing, and then watch for the progress and outcome of our care.
Thank you very much. Thank you for that, Mrs. Babalala. Josephine, final question today. Josephine, ask your question, please.
Thank you very much for this opportunity. I want to really appreciate the organizers. Thank you. Thank you. My question is about a food ulcer, particularly these diabetic foods, already booked or planned for amputation. If Doppler USS is done and it reveals that there is no arterial sufficiency, is there any hope that the leg will heal up?
Hello?
Yes, go ahead.
Which one? Is it the one that was presented?
No, I'm talking about, currently I have a patient in my unit that we are managing for diabetic foot ulcer, and it is really extensive.
Good.
Now, she's been planned for surgery, amputative surgery.
Yeah.
So my question is that, despite the Doppler USS revealing that there is no arterial sufficiency, is there still any hope that the ulcer can heal up?
Oh, no, when you have when you have arterial insufficiency, is a compromise. It gives you a very low percentage of the survival of that limb. That is the truth. Depending on the degree, because in the past we have vacuum tests, but the last 1 year now is not even available again. Vacuum tests assist in blood supply. But when you start talking about arterial insufficiency, I mean, the prognosis is very, very poor. That is it. The ones we survive, the blood supply, the arterial blood supply to those limbs with Doppler is still good.
Okay.
Yes. So because there is no magic we want to do, unless you want to bring in the cardio thoracic people that will do shunting, okay? And it's a 50-50 procedure. It's a 50-50 procedure. So with arterial insufficiency, the prognosis is not usually the best.
Okay. Thank you.
Thank you very much. And unless any one of the panelists have anything to add to that, that will be our last question today. And I will say we bring this to a close.
You've forgotten to talk about our Wound Care Association.
Yeah, go ahead. You can do that for 1 minute quickly.
Okay, thank you so much. With the passion for caring for wound over the past years and seeing the need for our patients to be served better, we have started a Wound Care Nigeria partner after Wound International Wound UK, like you have Canadian Wound Care Association, other associations over the country. We want to start an association in Nigeria. And I've sent my contact. We are taking off from Teaching Hospital Ife, but we are spreading out to all the states by the grace of God, so that we can form a formidable team and to be able to serve our patients better.
Fabulous. So if anyone has any more questions about that, you can contact Mrs. Babalola. Her contacts were posted in the chat. And with that, I would say thank you very much to all our presenters, all our speakers, all those who have supported in the background, in the foreground. Some of them I have left. And I will say good night. Please email me if you have any comments or any ideas of what we should cover in the future.